So after today, everyone will be practicing. It's the most important part is after today that everyone get on the machine and start doing evaluations and placing sensors. Most valuable piece of the training is the practice afterward. If anybody waits a week after today, things will start to feel a little rusty. Often it might be a fear that might be causing them to avoid the practice, and then that fear would only grow with time. Where the only way one can get comfortable with this, there's no amount of learning that will ever make somebody comfortable with this technology. No amount of learning, no books, no. You can do all the training. It's only with practice that one can get familiar with it. It's the most natural thing in the world to be fumbling with sensors, having your paste on this side of the room, your sensors over here, your equipment there, until you develop some like muscle memory for all of that stuff. And so the practice is by far the most essential piece in replicating our results. The software is very easy to use. It's set up very much like an ATM machine, but you know how it would be a little challenging for you to describe to someone all the steps of depositing money into an ATM or taking money out of an ATM, but when they're there with the machine, it's all pretty intuitive. That's very much like this, where the machine does everything for us, except it can't put the wires on people's heads. That's the only thing the machine really can't do for you. And so the practice piece of it happens with that. So if you schedule a time with Rihanna for next week or over the next week, then after today and you've ran a session on yourself or someone else, you've done an evaluation, then she checks in with you and you'll likely feel like you didn't know what you were doing. But she can confirm whether, what you did understand or what you still need to understand after training day one. Because after today, we won't be learning more about placing sensors or with the evaluation tool, which are the root of all the training. So that's what that was about Rihanna. So there's a link in that email that goes right to her calendar. Does that make sense?
Yes. And can we pick any time, or does it have to be the second Thursday or second Friday? Or can we pick anything that's open?
Yeah, anything that's open. Yeah, anything that's open. And then if when she's not available, you also did you have a link to my calendar as well in that email?
Just hers.
Okay, I'll put my link in the calendar also, because we have clinical support people available 5 days a week. And there's no additional costs or fees or anything like that with it. It's all a necessary tool. It's all having clinical supports is valuable as having equipment when it comes to getting up and running. And what we love to do, we're all about teaching you what to do with all clients. And we have endless patience for that. When it comes to an individual client, when you first start, often it's about an individual client that will be helping you, because that will be helping you with all clients. But that's something that's not so intuitive, because everything else in mental health, you have to learn all these very specific things with working with depression or character disorders, or people with cognitive deficits and post-traumatic stress disorder, developmental trauma, what have you. There's all these different things that with other technologies that you have to learn all these different things. But with BrainPaint, there isn't. There's just two types of training, infinite array of the two types, but there's two types of training in the platform. This alpha theta that has to be done with the eyes closed, and everything that's not alpha theta. And when we use our assessment tool, it comes up with the best protocol that's going to yield the fastest and most observable results with people. But when, often people will start out with some challenging clients and things of that nature, and you won't know if you're doing it right or if it's wishful thinking with the results you're seeing quicker than we said they're likely to happen. We're always here to help assist you in that. And if anybody has any trouble with client retention too. Like there shouldn't be a client who would ever do under 12 sessions with neurofeedback. Under 12 sessions, nobody should ever do that. No one, if you have anyone who isn't doing more than 12 sessions, that might seem like an odd thing. How on earth could BrainPaint help with client retention? The answer is we do it all the time when that happens. There's just one of a few things we'll be giving you today that assists with that. But if you're having any trouble with that, it's always related to how we're talking to people about it, not what we're saying ever. It has nothing to do with what we're telling anyone. It's how we're telling people about this. Is everything, everything, everything. Okay, we'll be talking a lot about that throughout the course as well, but it's primarily aimed at replicating our results. Who here will be working with kids who are 8 years old or under? You will. What is the nature of your practice, Alexandra?
I work with kiddos. My youngest right now is 4, and I go all the way up to like age 60. But I will be mostly working with kids with ADHD and really severe trauma. So I work at a school that's outside of Springfield, Missouri city limits, and they have about 25 clients that it's a very underprivileged, high trauma area.
Nice. Very good. Yeah, it's a big game changer. One thing about that with kids who are before they hit puberty, they tend to respond much more quickly. And what you probably noticed, all of you throughout the years, or if you reflect upon it, almost everyone who has issues that are more what we think of as more biologic in nature, the things that people are born with, when depression, bipolar disorder, things of that nature run in families, when they hit puberty, they often double or triple in severity. So when we do this with kids who are pre-puberty, we tend to really ease the ride in life, which is all this is about. Is easing one's ride in life. And virtually everyone who's done 12 or more of these sessions will have a permanent impact every day for the rest of their life. The quality of their life will be significantly enhanced. Of course, we can never promise anyone any results for any modalities ever, but as we'll describe how this works, is just like developmental learning with anything like riding bikes or snowboarding or things of that nature. And so trying this, the most valuable thing we can tell people about the technology, the first 2 words out of our mouth is 12 sessions is what trying this is, and then go on to explain what it is. But those 2 words are the most valuable thing we can tell people, because it's not intuitive. Otherwise, they would think that, oh, I see, you put the sensors on my head, I feel these wonderful feeling emotions, and then eventually my brain sticks in those states. Nope, it doesn't work that way. What it doesn't give people pleasure. What it does is it reduces suffering, and very fast. How many of you work with people with addictions, or you be applying this with addiction populations? All right, Clayton. What is the names of your programs? Wes, Christina, and Clayton. What are the names of your programs?
Oro Recovery.
Oro Recovery. Oro Recovery? Formerly known as Oro House?
Yep.
Ah, very good. Very good. Welcome. And is that same with you too, Christina?
No, I'm at Gulf Breeze Recovery.
Gulf Breeze Recovery. Excellent. And how about you, Clayton?
Cognitive Healing Institute.
Awesome. Very good. Awesome. Very good. One thing that Wes could do, because Oro House has been using BrainPaint for about 5 years now. Wes could confirm an amazing anecdotal statistic that in the last 18 years we've been in business, we've had tens of thousands of addicts undergo this methodology. And big deal. of all of the tens of thousands of clients who've done under 12 sessions, we can't begin to count the number of them who have died from relapse-related deaths. However, among those who've done 12 or more sessions, we can only find 10 who have died from relapse-related deaths, who've done 12 or more sessions with this work. It is the only population, this is literally life or death with our addicts. And it's not that they don't relapse. We do reduce relapse by about 55% when this is added to an addiction treatment process in every replicated work with my specific methodology. There have been 10 replications of my work with addict populations with this specific methodology. But when they do relapse, there seems to be a phenomenon that we saw in the very first clinical trial with neurofeedback back in 1969. A man by the name of Barry Sturman did this with cats, his sensory motor rhythm. That's all part of BrainPaint as well. He did that training with cats, and it made them immune to a neurotoxin that killed the mammals and or caused them to have seizures. The cats that did this didn't. I suspect that's why a significant factor when people do relapse, even from fentanyl addiction, it's extremely rare that they die from it when they overdose or what have you. So that is a really big deal. And all you have to do is you ask your clinical director or anyone who's been in your facility for more than 5 years, and you have the client list of every client you've ever seen. You can identify the numbers of sessions each of them have. And when we do that with facilities who've been doing this for years, they virtually never find anyone. It's like, wow, all the ones who tried it and saw if they liked it, after about 5 years, a large percentage of them are dead. However, all of them who did 12 or more sessions, and even the programs who insist that everyone do 12 or more sessions, they virtually eliminate client relapse-related deaths. Nicole, hi.
Hi. Sorry, I have a question about that.
Yeah.
For the reducing relapse, is it that it's not actually reducing them to like go for the substance again, but that if they interact with the substance again, their brain just reacts differently to where they don't have as bad of an outcome? Is that what you're saying?
Good, very good question. The majority of them will not even attempt to use after they've done this work. They engage.
Okay.
They engage in the ongoing recovery process. So in your treatment center, most people, when it comes to addiction, will avoid the real treatment throughout the process. Their tendency would be, oh, could I just sit by the pool and smoke cigarettes for 30 days? I just need a break. But when they do this work, they have significantly more of them. This is an anecdotal observation we've seen in the clinical trials, that significantly more of them start doing the work. Like a lot of them will think that they've gone to 12-step, they've done the 12-step program before, but they would only go to the meetings. They would never do the treatment. The meetings are like the waiting room of a hospital, and they're going to the meetings, but they'd never asked a sponsor to take them through the book, which is the actual treatment. So there's this delusional part of them that seems to wake up and start doing things they've never done before, regardless of the number of previous treatments. And then after treatment, they'll secure sponsors in their communities, or in faith-based recovery groups, they'll engage in faith-based recovery fellowship and things of that nature with very similar principles that they're living by. Both seem to be quite effective. Some have also engaged with smart recovery as well. But it's a thing that we just reduce the resistance to an already effective treatment with this work. And this is something too I'll be covering a lot of. I'm increasingly fascinated with this phenomenon of where does neurofeedback end? What is it that we can do 24/7 with this work, and pretty much only this work, and or really good medication management for these issues that are more biologic? And what can't we do with this work? What do we need you for in this work? There's things that we can't do, like neurofeedback can't give people relationship skills. We can significantly increase their learning of them, but we can't just deliver that to them. And so with addicts, for example, people could bring in their 40-year-old hotheads all day and say, fix them without any other work. It doesn't work. They very rarely will just spontaneously stop using their substance of choice. But when it's combined with anything, even if they are going to meetings, even if they were only going to the waiting room in the meetings and not getting the sponsors, they tend to start that work. But when they're not willing to do anything for it, and this is supposed to be the cure, and this is only for addiction I'm talking about, or I would say addiction and character disorders as well, where there's a commitment to a certain distorted belief system. We can't touch that with neurofeedback. We can't touch anyone's belief system. We can't touch someone's personality directly and suddenly have them become more other-oriented and things of that nature. We can assist with that, but we don't make it. But what we do all day are these horrible states that a lot of people's brains are stuck in, with major depression, where they were just born too slow, sleepy, and weepy. They hit puberty, like I said, in the doubles and triples in severity. And they're cutting because of dissociation and things of that nature. That is the easy stuff. Or bipolar disorders, the more severe, the better starting candidates they are. So people who are psychotic and things of that nature, because of bipolar disorders or schizophrenia or what have you, are the easiest populations to start out with, because those issues are clearly more biologic in nature. There's no choice, there's no willingness that's involved. When people are lacking the capacity for functionality, that's what BrainPaint shines in. And this assessment tool we'll be teaching you how to use is what delivers those results that are related to the capacity for functionality. And then in the programs, what happens is the clients, there's always a negative support group in every treatment center, people who aren't so committed to growth and are committed to holding on to their old ways and things of that nature. And when we introduce BrainPaint to these programs, the size of that group shrinks significantly, and the tension in the overall program reduces significantly. And increasingly, our centers are getting enough equipment so that everyone can receive sessions, multiple sessions a week, to ensure that they all get at least 12 sessions, because you can do up to 3 sessions in a day with people when they're only going to be in your programs for short durations as well. Other questions? Yes, go ahead, Nicole.
Sorry, I have another question.
Yep.
For using BrainPaint with clients who have bipolar disorder or schizophrenia, do they have to be medicated in order to see a change, or can they be like in this state where they're not even pursuing medication because they're just not doing well?
Doesn't matter one bit. Anything, I mean, if
Wow.
a medication when it comes to like real schizophrenia, where it comes on in the early 20s, mildly, and it's progressing. One thing with that population is they rarely will show up even for their initial session. You may get them on your schedule, but they'll rarely even show up. So if a medication would be helpful so that they could show up for a session, great. But if they're already involved in your program, no. The worse they are, the quicker we see results. And that's about the only population that, with the eyes open training, that in one session you can see effects from one session. With people with moderate to severe bipolar disorder or psychotic features or things like that. And the cause never matters, whether it's THC induced or, what have you, or from a head injury. The cause never matters. That's a thing with the assessment tool that'll be, just take experience for you to wrap your head around when you do the assessment as we train you how to do it. You don't have to be concerned with, I've never worked with someone who was blind from traumatic brain injury. They would get the exact same results if they were seeing me as if you were seeing them when you use our assessment tool as we're doing, which is very, very easy as well. Other questions? And by the way, in the last month, we've had 3 people who were blind from traumatic brain injury get their sight back as well. That is not the exception. That is the rule with this work. Traumatic brain injury is one of the easiest things also. Again, why? Because it's related to their capacity for functionality. If somebody wanted to procrastinate less, if they lack the capacity for that, yes, that would improve significantly. But when it comes to discipline, that's not that we don't make somebody more disciplined. Like the kids with ADD may not be able to clean their room. We can give them the capacity, but that won't make her suddenly want to start cleaning her room or becoming more disciplined. But that's quite different. A lot of times people with depression will feel like they're lazy, and that's why they're depressed. And that's a narrative that's been dumped on them a lot of times for people who weren't so effective with them, I would say. That is not discipline. That's related to their capacity for functionality. And BrainPaint can spot that really effectively without even a single word in the assessment tool about depression. It's just from the nature of the behavioral outcomes of different 3 primary roots of causes. Other questions?
I have one. When you are dealing with kiddos that are on ADHD medication, how do you get a proper baseline so that then you can show proof that, hey, this is actually working, we need to slow the dose? And then how do you convince the doctor? Obviously, you have to convince the parents probably first, but then how do you create a baseline to get the parents on board?
Yeah, that's excellent. The most common, one thing that's nice about stimulants is it's a particular drug that they don't have to keep levels up and things of that nature. Quite frequently, they don't have to take them on weekends, and the parents can not give them on a weekend and see how they're progressing after they've done a few. And when it comes to the doctors on board, very good question. There's a culture in my field of EEG biofeedback that unfortunately hasn't been so inclusive of medical professionals. And as a result of that, because I've been in this field for like 30 years, and I lecture 6 times at the American Psychiatric Association's annual conference. So I have a really good feel of how neurofeedback is seen. And what I'm getting from that is we haven't been playing with them in the sandbox. My field has like this attitude of we don't need you. What we have is better than you, and then they're like, we don't need you because you're this fringe science type of a thing. It's like, but there's these things affect like the zeitgeist. It's not like they consciously say that to anyone. Nobody's ever said that to psychiatrists, but it's sort of an attitude that I see. And in talking with psychiatrists over the years, about that, that's kind of what they feel. And so an example of that is when it comes to TMS. Every psychiatrist I know who refers to that rarely sees it work. They rarely see any efficacy. It's always chemorefractory depression, people who are not responding to antidepressants who try it. But why do they refer to it all the time? Because they have to, because they're included with it. Their expertise is necessary for the referral for it because they're included in it. And when they say it's like, if we included you like this with that, would that be helpful? Yeah, it's not about the research. It's not about how prolific it is. They've all heard of it by now. It's just they don't feel included with this work. And that's something that there's a lot of room for it. Like really good psychiatrists can stabilize schizophrenics pretty quickly. So they would show up for the session, for the initial evaluation to begin the training and things of that nature. There's definitely a place with really good psychiatrists. They sort of know what to do to get some immediate mood stabilization and things of that nature, though it's not necessary. One thing that's important to know, it's not necessary for everyone that they're on meds before they do this. Anything that's necessary for them to show up for sessions, great. Another thing about drugs, this is so not intuitive, is that there's only one drug that seems to be a contraindication. And those are, and however, people on this drug, the dose never matters. If it's a daily dose, 50% make just as much progress as anybody else. You wouldn't know they were on it, no matter what the dose is. The other 50% will make no progress whatsoever. That drug is benzodiazepines. It's the only drug of every drug. No combinations, no nothing. Seroquel in the treatment centers where everybody's getting the same dose regardless of their body size and their slurred speech the next morning. We did 2 clinical trials in that for ADHD and normalized attention variable attention in 1.5 weeks. I thought, oh, there goes our study. Before we started, it worked just as well. With them. And in no clinical trials have any drugs been identified as being a factor, not even benzodiazepines, but it hasn't been, there wasn't always the drugs. That's an anecdotal observation that we collect. Benzodiazepines, Xanax, Valium, Klonopin, lorazepam, that class of tranquilizer drug is the only drug that can. BrainPaint also illuminates that with you, so you wouldn't even have to remember that. When you do the assessment tool, that will come up in it. As well. We're going to do an experiment today too, where we've always been at the heart of BrainPaint. We've always had AI developing our further refining our model of protocol suggestions, where now there's one that I'm beginning to integrate into creating these quantifiable growth areas, we call them, that comes to the assessment tool. So at one point, we'll be querying some of you, and I'll be giving you, I just made this slide right before we started, that has a ton of text in it that you can just copy into an AI model. Gemini, it won't matter which one you use. That will then assist you in creating these quantifiable goals. So your other last question I didn't answer, Alexandria, what are the baselines for the parents that we can show progress? That's pretty easy, because even on the medications, quite frequently the medications, stimulants, what have you, all classes of them tend to help with some of the behavioral aspects of it, but the inattention, the number of prompts that are required to complete a particular task, the number of hours it would take them to finish their homework, when not finishing it is not an option, I should say, reduces, whether on the medications or off of the medication. That's something that doesn't tend to improve a lot with the medications, but we'll be showing you how we can quantify that and make it really black and white. And it also makes it more fun doing BrainPaint more quickly. If you don't have these quantifiable goals that are the behavioral outcomes of the emotional issues, it just takes about twice as many sessions for everyone to get clear that someone's making progress. But when we create these quantifiable goals with this tool I just made this morning that I can give you all who have access to an AI model of any kind, it makes it a lot more fun because everyone can see the progress in like half the time, essentially. So we talk about recognizing progress within 5 to 8 bi-weekly sessions or 10 to 12 at once per week. That tends to be extremely conservative, as some of you who in your facilities have been using this for a while can see. So today's training, started at 10 a.m. Pacific time, and then the first 4 Fridays of the month. Next Friday it'll also be 10. All the Fridays it begins at 10 a.m. Pacific time. All the subsequent trainings will be 2 hours. And training day 1, we're going to be covering what is it? How do we do it? How do we use the evaluation tool? How do we create quantifiable goals? And then at 12:30, the most valuable part of the training, the thing that nobody can get from watching training videos or even from someone within your facility who's done this a million times, is placing sensors. It takes me 2 hours to train anyone how to place sensors perfectly. It takes me 2 years to teach someone to teach someone. So another thing with those of you in institutions, you can't be a bubble with this work. Your sensors are eventually going to be breaking. The gray cables will eventually be wearing out. Your IT person internally won't be able to help with that. So please don't let them touch the machine. There's a big sticker on every laptop that says, tech support. Call that number. Or there's a big red help button on the desktop of every machine. You can run that. That's the most efficient thing. And let us help you with that. It would be great if this could be like other things that have to be on essentially like conveyor belts in institutions, or they can't function like that if they weren't. But when this is on those, when it comes to clinical and or technical support, ensuring that everyone knows what to do, just let us train them. Also too, these Fridays begin on the first Friday of every month, but the chances are when a technician leaves and you have a new one coming in, that they don't have to wait a month. Have them get a hold of us. I'm going to give you all an app right now that is an invaluable tool. We just released this month, but this app is ideal. It's a BrainPaint app. It's super helpful in connecting with us and knowing, who to connect with and for what. It's all here in this app now. When it comes to ordering more supplies or any billing questions, changing credit card numbers or clinical support, you're not sure you're knowing what you're doing, or you're just wanting some reassurance with it, all of it, that thing where we talked about connecting with Rihanna and myself after training day 1 to confirm that you got everything necessary. All of that is here in this app. And I would encourage you to do. So I'm putting it here. It won't work on the desktops of machines. It'll only work on Android and or iPhone and mobile devices. I'm putting it here in the chat feature. And then copy that, send it, text it, whatever it would take to put that in your on your mobile device. And then you can save it to your home screen. Like, see that little icon there? You can save it to your home screen. So otherwise you won't be able to find it in bookmarks or what have you typically. And then you just click it like this. And this is how you'd save it to your home screen. I'm just opening up the app now. And then I think this is Safari, but whatever app there is, see that little icon there I'm pointing to? That little icon is the share. That'll either be at the bottom of the screen or it'll be up at the top of the screen, depending on the type of browser you have. But when you click that, it brings up this share thing here. So I clicked that little share. And so, do you want to text it? Do you want to this? Do you want to that? On iPhones, you have to scroll up to see the add to home screen. I had to click and scroll in an upward direction. See, I'm scrolling the options up like that. I had to click this and kind of scroll up to see that. Add to home screen. And you click it, and then the icon's on the desktop. And when we add updates to it, that will happen. One of the things we'll be able to add to that pretty quickly is that AI model thing that I'm showing you now with creating quantifiable goals. We're eventually going to be creating an app for clients also to document their own progress across sessions and to answer questions about what have happened since the last session. So when you go and open the client file, the BrainPaint software will just go and get that information and input it into the machine for you as well. So that's that. Everybody see that in the chat feature, the BrainPaint app there. Okay. And then, placing sensors, 12:30 Pacific time. We'll be walking you through a practicum of doing that. So if you have any new staff who come on board or other people who want training and it's outside of our regular training cycle, give them that app and say, contact BrainPaint. Don't try to train people internally yourselves. Again, there's no additional cost for us training them. It just saves us all a bunch of work and saves you a bunch of frustration from training them. They're having trouble getting connections and things of that nature. And then where do they go when they're having troubles because they haven't been trained properly with it? We can solve all of that. We find it's way more efficient for us to teach people who are coming in to do this stuff. All right. And then conducting the 2 types of training that BrainPaint delivers. So next week, it's going to be primarily about this. We're going to be covering next week a lot of details also in working with kids who are 8 years old or under, people with moderate to severe neurologic deficits, but then also how and when do we reevaluate people? What that means is, when should I do something different with every client I'll ever see? It's a very valuable training. It gives us about 25% better results with it. Now the software tells you when somebody appears to be ready to be reevaluated by the responses since the last session. When they plateaued, it recognizes that, and the frequency of sessions they've been doing it and all of that. And it can prompt you for it, but then it'll be, well, how do you do it? But I'll be giving you a cheat sheet next week for that. But that's a valuable piece of the training. And after those 2 days, the training day 3 is going to be on conducting these brain prints on people's foreheads that we see. Like right now, OCD or significant obsessionality is the only challenging population we have anymore with people where we would expect to have results with people. OCD. There's one of 3 different training approaches that's going to help with that population. We never know which of the 3 is going to be effective, but a third of them are going to require this training on their forehead, and that will be training day 3. Actually, all of them now we recommend would do it, even if the first protocol was effective or the second approach was effective. We want to do all 3 training approaches with people with OCD. That will prevent some overlearning. We'll get way more into that in training day 3, though. Any questions about today's topics or anything else? All right, everyone, let's jump in. So, after today, we'll be teaching you these 3 things. How do we use the evaluation tool to come up with what we call protocol suggestions? And how do we place sensors on one's head? And what's a simple language to explain it to clients? That's explaining what this is and explaining what to do in the 2 types of training that will come up during the actual feedback. These are some easy candidates. The common denominator here there's no secondary gains to these issues, meaning that there's no willingness involved. It's only a numbers game. How can I tell how much better someone is? How many sessions did you do? The most valuable question I can ask someone. And is that how many sessions did you? With these issues that are related to their capacity for functionality, their results are extremely consistent with virtually no delays unless they're on a daily dose of a benzodiazepine. But they're all related to their capacity for functionality. This would also include like generalized anxiety as well, or agitated depression. Also, those are related to one's capacity for functionality, where those moods just kind of shift like the weather, independent of things in the external world, and or reaction. It might be exacerbated by things in the external world. When they have PTSD, that is the night terrors and nightmares are the easiest thing we help people with. PTSD, developmental trauma, the severity never matters as well. That are the easiest populations. And like I said, it's also, how most of you are likely experienced with EMDR by now, and you've learned what a skill set it is and how to deliver it without re-traumatizing people and things of that nature. With this, that isn't necessary, that the software can identify people who will need to be eased into it from the evaluation tool, where some of them it'll only give them 7 minutes in their first session in this other thing for you to read to them in the session. But there's not a lot that you have to learn about every different population. The more challenging clients are these here. If your institution or your practice is not experienced with OCD and character disorders, then we recommend not starting with that population if you can avoid it. And the reason is with OCD, like I said, whatever their starting protocol is, there's only a 33% chance that it's going to have an effect. And what happens with that population is it's quite natural that, let's say, even with me, who has designed the software and been working in this for many, many years, they'll ask, what's that number? I'll explain, why did it go up? I'll explain, why did it go down and up and down again? And there's 50 numbers on the screen. How do I, every answer you give people with OCD spawns 2 additional questions. And when what's happening internally with them is they're feeling like if you give them the correct answer that it's going to be rainbows and unicorns from here on, every problem will be solved, and unless you give them that, their problems won't be solved. They're not saying that, they're feeling it. And it's easy when you're new with the technology to respond with how they're saying it, not what they're saying, and feeling like the biggest fraud who's ever walked the face of the earth when you're starting with that population. Though the results are the same with it. It's a numbers game. Fortunately, too, they tend to be very tenacious. They rarely will stop doing the work. But it can put a bad taste in your mouth around it because, 1, there's only a 33% chance we're going to have an effect on it. 2, you could get rid of their panic attacks in 5 sessions. When the OCD is still there, they'll be like, well, that's nothing. I'm still looking at my nose for a half hour. And it will feel like, yes, I guess that is nothing. Absolutely nothing. You just broke a world record in reducing panic attacks from people, or they might have had a head injury in addition to, and now they can see again. But that's nothing. I'm still X, Y, or Z. It will often, when you're new with the technology, it will feel like, yes, that is nothing that you're able to walk again or you can swallow again. You're still obsessing. You can't play the guitar after 5 sessions with a traumatic brain injury, or what have you. So those are some reasons why we recommend not starting with them. It works great with them. I personally had a terrible case of OCD before I did this in 1993. I've had no semblance of it. I was stuck an average of 2 hours a day in obsessive loops, preventing bad things from happening. I knew intellectually they weren't going to happen, but it felt like they were, which is classic OCD. Anyway, yeah, it works really well with these challenging populations. It's just you can get a bad taste in your mouth if you start with them. Character disorders also are a challenging population where it's quite natural for them to sense vulnerabilities in us. And when you're new with the technology, it's quite natural that we won't feel perfectly secure about it or know everything about it, for double binds to come up. And so it can just put a bad taste in your mouth. If somebody says, hey, if Bill said that when it comes to doing the eyes open only, when it comes to doing the alpha theta training, that will not work if anyone's eyes are open during alpha theta. I'm going to say that 5 times today. The protocols that are alpha theta will not work if someone does it with their eyes open. A large percentage of people with a borderline personality disorder will sense that term that you're holding around that and will challenge that and go, oh, I'm sorry, Nicole, if I do this with my eyes closed, it's going to trigger a panic attack. My panic attack is going to trigger tachycardia, and I'll be dead in a half hour. So could I please just do this with my eyes open? Whoa. And I'm going to kill myself if this doesn't work for me. So help me or I'll kill myself. But if you do this, you're going to kill me. Double bind. I'm exaggerating, what this is, but those types of dynamics often come up more so when you're using a new methodology that you're not yet fully comfortable with. And so that can be troubling. But again, whenever you have anyone too, if you end up at some point down the road working with this population, you feel like you need to be talked off of a ledge because they're renting a lot of space in your head. I will just say, outside of sessions, you're finding yourself thinking of them 3 to 5 times a night. Just set up an individual consult with that app with me. It goes right to my calendar. Put yourself in, and I can talk you down from that. And usually you're just looking for some reassurance with some things, with a particular person. But that's valuable because without that, it could often, other clients who haven't even seen that client will start having similar reactions through a transference, it's called. Yeah. But it has nothing to do with the feedback. It's just how that population may respond. This is not so intuitive here, but this will probably be most of you, where people with excellent minds and brains, their changes will not be quantifiable. They're going to be qualitative in nature. So if someone's doing well in work, play, and love, where they're not crying a certain number of times a week, they're not yelling a certain number of times a week, they're not frozen in fear, they're not making 5 mistakes per week at work because of cognitive issues, attentional problems, what have you, then how are they going to see results? We don't know where those results are going to show up. They always do somewhere, but it just takes about 3 months of hindsight to recognize, wow, I used to get a migraine before my menstrual cycle and cramps, and I haven't had those. I don't know when my period's coming anymore. Very common for things like that to happen. Or, yeah, I guess in these scenarios, I used to be quite reactive, but I'm finding that I'm kind of moving through them and being more interactive and curious versus judging the outcomes and things like that. So those are going to be more qualitative in nature. It works great. It's great to get practice placing sensors and getting over that thing we talked about where it's likely to you fumble around with things more. It's good to practice with them. Just don't expect to see clear results. When people have issues you could clearly see on a video camera on a daily or weekly basis, where they're yelling or crying or engaging in conflicts, with others, or avoiding certain things that are creating consequences in their life, it's very easy to see the results very quickly. Or another thing too, all instruments like the GAD, the Symptom Checklist 90, Beck Depression Inventories, PCL5, those are beautiful as well. If you have access to any of those and you want to see very quantifiable results, we have one built into the software called the Symptom Checklist 90. One can administer as well. And those are very sensitive to the effects of this specific type of neurofeedback. They're not all created equal by any means. But those can be valuable. Another thing too that can be challenging, Alexandria, when it comes to starting with people, as you're quite familiar, you'll have parents who have more issues than the kids. And when you have any kids, particularly with attachment disorders, which you mentioned some have, the parents looking at the kids are going to cause reactions, even when they just do a 7-minute protocol. It's not the neurofeedback, it's just now they're under an electron microscope and they start reacting more to it. So that can be challenging if you can avoid starting with that. When I'm saying avoid starting with these people, I'm only talking about when you just have 5 or more sessions on 3 or more other clients. And classically, we're breaking records in terms of symptom reduction. And you're getting that no one's growing antlers with the work. Yeah, you could review all the adverse events from all my clinical trials and things of that nature, and see the only one were rashes that developed on people's ears when we're using this stuff called new prep to prep their ears, that some people would develop rash. That's it. In 50 years of research and clinical trials, those are the only negative things that have ever happened. And I'll get to why that is in a moment. This one here is not so intuitive either, that if an issue is only occurring in one relationship, that relationship needs more therapy than anybody's brain likely needs to be trained. And that is one of the things that I talked about. That's where BrainPaint ends and this begins. When it comes to codependency, for example, where someone is feeling worse about the control that they have over another person than anything that an individual is doing. That's how I would define codependency today. This will not help with that. We can get rid of all of their PTSD, all of the developmental trauma, all of the depression. We can help with all of that stuff, but it's not going to suddenly cause the spiritual issue to improve, where they believe they should have control over things they don't, and they're frustrated over their lack of control over the external world like that. That's a spiritual issue that we can reduce the resistance to it, and when they're engaged in a therapy that can, like DBT or what have you, that can, or 12-step work that can adequately affect that, then they're more likely to do that work or go places they couldn't go before. But we're never going to change somebody's personality with this work. Fortunately, it's just a universal rule. And we're not going to change anyone's belief systems exclusively with this work. And that's where therapy begins, where when someone is seeing you, they're often catalyzing with whatever truth you have within you to help them move in that particular direction. But it's not just suddenly going to cause people to just instantly let go of their delusions like that. They have to catalyze with an already effective treatment for that. Any questions on any of that so far? Yes, Nicole.
Sorry, I'm like the question master. Um, does this work for people experiencing like physiological symptoms of anxiety or depression, like if someone's having insomnia or even like irritable bowel syndrome or things like that?
Bowel syndrome is quite different from like sleep issues. Sleep tends to be one of the very first things we see impacts on. For those of you in addiction treatment centers, you're probably aware that somebody's been detoxed off of benzodiazepines for 6 months to 2 years, and they're still having sleep problems. That tends to normalize most quickly before we're actually even getting some definite quantifiable goals. Within 1 to 3 sessions, we usually start seeing sleep improving and some other behavioral responses that BrainPaint asks questions about. So yes, we do tend to see those. But when it comes to irritable bowel syndrome, that's more of an autoimmune disorder. And when to the extent to which it's exacerbated by stress, we can help with that tremendously. But we don't make that problem just go away, unfortunately. Yeah.
Can I add on to that question?
Yeah.
I've read the books like When the Body Keeps the Score and You Have Deadly Emotions, stuff of that nature, where those physiological responses are based on reoccurring trauma or like CPTSD type symptoms that then manifest physically. And so if they are having those issues and they were diagnosed with like PTSD or stuff of that nature, they should correspond with helping those physiological issues if we're treating the PTSD or the depression or the anxiety, right? Shouldn't they go hand in hand?
Everything that's significantly exacerbated by stress tends to improve significantly. I'm quite familiar with that book, and its author and I have been in dialogues for last 15 years. He has BrainPaint as well, but there's some overreaches, I would say, with it, where they tend to kind of blame more of the psychopathology on the physiology on the psychopathology quite frequently. I would also say too that the methodology that him and the group he's with that are married to, they don't do alpha theta sessions with the eyes closed. And in my observations and his experience, even with integrating this with developmental trauma, it seems very watered down. And you read that book too, he doesn't say that they're hopeless and just have to deal with it for the rest of their lives, that there's nothing they can do with it. But I get there that that's implied throughout that book, that we just have to teach them to cope with it. Your body, it keeps score, and you're damaged. That's a very subtle thing. And another thing too with it, he was also trained by a clinician who I had trained many years ago with neurofeedback, who, when I thought alpha theta training was the hammer and every problem was a nail. She had a negative reaction to alpha theta and ended up being quite fearful of alpha theta. And then it's kind of created sort of a watered down version of it. And when a lot of people that she trains to do neurofeedback, when they do alpha theta, they have all these negative reactions through transference because there's like this contagious element of transference that happens with. I had the same thing happen. I was trained by Eugene Peniston and told everyone I do alpha theta sessions with has just so many flashbacks in them, and they have these horrible ab reactions. And after they've had a number of them, then they get better. And I believe that every client I had those horrible reactions for about the first 12 to 15 of the population he worked with, Native American veterans, severe PTSD from the Vietnam theater. They all had those horrible reactions until I did my own training and recognized how my expectations of that happening were setting them up for it. And I also see when people have read that book or similarly have gone through that particular trainer's training courses, their clients all have these very unique reactions to it. It's just a phenomenon that one should be aware of, yes, there are physiologic issues. Whenever anxiety is exacerbating some other physiologic concern, we're likely to have an impact on it. But I would definitely not say, and the book doesn't actually even say that they're all related to psychopathology and we resolve the underlying issue and then those problems completely go away. But it seems to be implied. It's easy to walk away with an overreaching understanding of like the immune system versus trauma and that as well. Yeah.
I think I'm picking up what you're putting down. Thank you.
Okay. Yeah. That there's to the extent to which like people with migraines quite frequently, when anxiety levels are triggering that, we can have an impact on the migraines, though it's not the typical, it's not when migraines are the primary thing that are detracting most from the quality of one's life. That's not a stress-related disorder. So the alpha theta will help exclusively with stress-related disorders. Those are issues that started from the external world and now come up in reaction to the external world. And yeah, a lot of things will be exacerbated by them, but not everything. Yeah. Okay. We covered these already. Oh, dyslexia, where people get left and right mixed up. We rarely have an effect on that with the basic protocols. Not to be confused with other visual processing disorders. We tend to have a big effect on them, but just when people get left and right mixed up, or they meant to say group A, but they say group B, like I do, or spelling seizure, which I use every day. Just did a study on some seizure data with it. I can't spell it. Is it E-I-I-E? Anyway, it doesn't help with dyslexia. Rarely, I should say. We do have some experimental protocols with it. We covered benzodiazepines. We'll show you some more on that when we get to the assessment tool as well, where benzos is the only drug that we don't see someone respond. And when it comes to contraindications, Christina, yes, you had a question, and it showed me it through the help button. Rarely it does that. Go ahead, Christina. Yeah.
So when you say that it doesn't help with dyslexia, are you saying that neurofeedback will not help with the issue of dyslexia, or that dyslexia prevents us from helping with other like depression, anxiety, stress, whatever issues?
Glad you asked the clarifying question. Yeah, no, I was in the way I said it was exactly as it was, because most people with dyslexia also have significant attentional issues as well, and other auditory and visual processing issues also that we tend to have a really big impact on it. Yeah. So, yeah, just the dyslexia itself doesn't tend to respond. Of course, there's anecdotal cases where it does, but by and large, it doesn't tend to. across the board. We do have an experimental protocol. If any of you have it and you've gotten your feet wet with some of the basics for yourself, but not paying clients per se, I'd love to turn you on to that at some point also. I did that once with some, I don't know, about 5 or 6 providers. It was quite effective for them. Personally, I only did 6 sessions on myself, which is typical if somebody just does like 6 sessions that are very intermittent. They might have some gains from it, but they'll virtually always lose those gains. And I lost most of them that I had gained from those 6 very intermittent sessions on my own dyslexia with that experimental protocol. And there's other things that I like to do more than that as well on myself. My dyslexia doesn't bother me that much. Yeah, we covered this already, and we'll show you in the assessment tool.
Hey, Bill,
Yes.
a question related to that last one. So I do have dyslexia, and dyslexia is kind of a way it's just the way the brain works in aspect. And so, sorry if I'm not making this clear, but autism, again, is just a different way the brain works. And so how much effect does this have on autism, or does it necessarily adjust the autism, but it helps work with the anxiety, depression, and those aspects?
I'm going to cover that right now. This is everybody. When we looked at 13,490 clients, regardless of what they were coming for, the results, where after 2 sessions, 45% were reporting issues being either better or resolved, or the same or worse. And by 5 sessions, we're up to 63%, up to, after 20 sessions, 80% of everyone, regardless of what they're coming for, out of 13,490 people. Then we break it down into specific populations. This is the most responsive. There were 222 in this particular cohort, and 85% of them with night terrors and nightmares. The cause never matters. And after 2 sessions, 62% are reporting progress. This is, anecdotally, is pretty significant progress, where they're usually a lot better after 2 sessions. But yeah, that's the most responsive. The next responsive is PTSD. We're here, there's 819 in this particular cohort, and we're up to 89% after 20 sessions. And this is the growth curve that starts to plateau around 20 sessions as well. And then when it comes to autism and Asperger's, one thing we see with that population, they respond, regardless of the severity, they respond very well. It takes them 10 sessions, though, to get to the same place everyone else does by 5 sessions. And then by 30 sessions, then they're up to like 93% of them are breaking records in terms of symptom reduction. And so it takes them additional 10 sessions to get to the same place, but it's the only population that seems to take longer. One thing with that, we have to re-quantify this. We've built in many better tools into the software. We have this movement shaper now. Possibly one of the effects of this is, before we had a thing that conditions people to be still in their sessions. There was a lot more movement in their initial sessions. That might be why it took 10 sessions versus 20, but these results are off the charts. And these are every quantifiable goal you can imagine. This is with 354 people with autism and Asperger's. They're a very easy population to work with. Like I said, the only population that we see are people with dyslexia that don't respond real consistently, and 50% of people who are on benzodiazepines. But yeah, every other population, this is insomnia. Everything else is basically like 80%, except for OCD. Bipolar disorder, yeah. But yeah, OCD. What we see with OCD is that after 20 sessions, there's still 25% of them are at square one. And that's our worst responsive population, where we would expect to have effect. When it comes to chronic pain, there's nerve damage. We will never make that nerve damage go away. So if there's a botched surgery in their mouth, so we wouldn't expect to have that But with chronic pain, that it would be technically, this is, how many was this? This is with 337 with OCD. This is 298 with chronic pain. So here we see that on average, by 10 sessions, 65% are improved. But after an additional 10 sessions, they're pretty much the same. And where we'll just call this that 66% are helped. That 66% who are helped, I would say those are people with PTSD who've developed chronic fatigue and fibromyalgia, which are a large percentage of people with fibromyalgia who have very chronic pain. That goes away. Another thing too, and I would say anecdotally with interpreting this measure, is that with chronic pain, when there's an unidentifiable source of the pain, which tends to be the majority of people with pain, back pain, whatever type of pain, when they do x-rays, MRIs, what have you, they can't see the cause of it. That tends to be who comprises the entire population of the 67% who are significantly better after 20 sessions. And the other third, who are still at square one, would tend to be the people with the no nerve damage of the pain. So yeah, that's a whole breakdown of the entire cohort of people. When it comes to there's graphs on depression, anxieties of any type, the results are the same. It's like that first graph here that captures it all. Yeah, autism is the only one. It works great, like I said, with them. It just takes maybe an additional 10 sessions. I suspect that will be different with how the software is now with this movement shaper. We're covering next week in working with people with moderate to severe neurologic deficits or kids who are 8 years old or under. All right. So this often begs the question, what other contraindications are there, Bill? There are none. What about pregnant women? People with seizures? If images flash, isn't that going to cause seizures? Very common question. We get that about once a week. Usually it's people just wanting confirmation. My clinical team is concerned that the images flash. Is it going to cause seizures? No. One thing about that is it's even of people who have seizures who happen to be triggered by those flashing things. It's very rare. It gets a lot of media attention, but it's very rare. And the flashing has to be this very bright and a consistent frequency, which BrainPaint can't do. It can't make a bright and consistent flash for a long, prolonged period of time, for minutes, to cause that to happen. So people can't cause seizures. The worst thing I've heard of people with seizures is we only reduced them. When it came to Barry Sturman's original research, where I was speculating why aren't the fentanyl abusers overdosing and dying when they relapse, is it's likely back to Barry Sturman's original work with cats, where he did the SMR training with them, and it made them immune to the seizures that the cats had. He went on to speculate that, wow, if this is preventing seizures in mammals, what if we did it with humans with seizures? And he did a very beautiful clinical trial with people with seizures. And with that old equipment back in the late 1969, he was able to reduce the seizure activity by almost 70% less seizures. So the worst thing I've heard about people with seizures is we only reduce them. Usually we get rid of them. Rihanna, who just tuned in here, our clinical support rep, actually had 2 piglets with seizures that she had a big impact on with doing very infrequent sessions. I don't believe they did even more than 10 sessions, but had a significant impact on their seizure frequency, which were very observable. Cochlear implants, are they going to cause a problem? Hearing aids, no, or anything else in the last 50 years. And we covered this already, that the only adverse events we've had in our clinical trials were people developing rash when we use this overly abrasive product on their ears. Now we use paper towels and isopropyl alcohol. Never, ever, 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 ever to be confused with, I got everyone's attention right now, with alcohol swabs. Do not use alcohol swabs ever, please, promise me. When I've emphasized it like this in our trainings, we pretty much have eliminated that, but those tend to be a significant cause of our technical support issues when people start using them because they're available. They're not abrasive enough, like paper towels. Okay, that's why we emphasize that too in the pre-training email. Be sure to have paper towels, never alcohol swabs, and probably a big paragraph of why to not use alcohol swabs in our training practicum at 12:30 today. All right. All right. No contraindication. All right. There is that. So how does this work? What is it? What's a language we can use to explain it to clients? It's very simple. It's so simple that I don't even need to give you analogies like that to explain it. That when it comes to how we feel and how we think, there are three root causes of every diagnosis in the DSM-4, other than belief systems. That's where the talk therapy comes in, or education, psychoeducation. So the root cause of nearly every diagnosis is underactivation, where people's brains are running too slow on the arousal continuum. That's where, in the most exaggerated cases, are people with major depression, where they kind of look like this. They talk slow, they move slow, they can't sleep more than an hour, always interrupted sleep, nightmares during the night, and always daymares during the day. And their brains are running too slow. Down in this, their performance and everything they do and their emotional regulation will be really, really bad. Then there's people whose brains are stuck in over-aroused. This is called the Yerkes-Dodson arousal law, not theory, but the law. People whose brains are stuck in a very over-aroused state. These are the people who have impulse control issues and generalized anxiety, where their hearts race and they kind of feel anxious and sweaty. And if you're, what if I get a bill in the mail today? Oh no, it'll feel like the world's going to end. Or agitated depression, where they're irritable and angry and frustrated with everything. As well. Those are over-aroused states. Their brains are stuck in these states that run too fast. Well, Yerkes and Dodson back in 1908 identified, in looking at performance, boy, the best performers in the world, brains are in this optimum level of arousal. Here, they're not running too slow, and they're not running too fast, and their mood and everything they do is better than people who tend to be more stuck in under or over aroused states. The brains are running too slow or too fast. You can easily think of it as. This is my second favorite clinical trial that I knocked it out of the park, explaining precisely what BrainPaint is doing for these issues that are more biologic in nature. This study found a group of these Air Force pilots who were failing the flight simulators. They'd ordinarily be ejected out of the Air Force because if they fail the simulators, they always fail the real crafts and crash them. So they found this group who was stuck in the over-aroused state with these very specific physiologic measures, including crashing the simulators, blown out pupils when they're about to make fatal errors, and heart rates racing abnormally fast. And then they gave them a type of training that BrainPaint delivers called SMR, the sensory motor rhythm training. So that's all they gave them. And they found that they could move them from that set point where they're stuck. These are traits we're talking about now, not just states. These are the traits, the things that the person's born with. We shift that with BrainPaint. When they're stuck in overactivated state or stuck in an underactivated state, our assessment tool comes up with a training strategy that will be the most likely to move them and on this arousal continuum more to this optimum level. This particular clinical trial identified that with a large group of Air Force pilots, that they could slow them down and improve performance with that particular aspect of BrainPaint. Another thing that happens, so those are in the DSM-4. We covered like the under-arousal major depression would be a great example. Inattention, type of an attentional problem, would also be in the under-aroused category. Again, you're probably thinking, oh, do I have to remember all of that to use the assessment tool? No, we just have to ask the questions and that the software gives you, asks, and then it comes up with how much somebody is stuck or not. The third root cause of people, so there's under-arousal, that the beta training tends to help with. The over-arousal, that helps with the slowing people down, with SMR training helps with. Then there's the hyper-reactivity, the stress-related disorders, when those are detracting most from the quality of one's life. It's the alpha theta protocols that tend to have the biggest and quickest impact on them. So I'm going to say this a bunch of times too, to wrap our heads around it. BrainPaint doesn't care if somebody has PTSD. It doesn't care if they have I'm sorry. It doesn't care if they have depression. It doesn't care if they have generalized anxiety. It's not going to be helpful to know how horrible the trauma history was that an individual had. It won't be helpful for the assessment tool to come up with the best training strategy. What it cares most about, of what do you think is most detracting from the quality of life. Everybody, to some extent, will have some stress-related disorder, some insecurity from events in the external world that now come up in reaction to the external world. It doesn't care if they have it. It wants to know, do you think that's detracting more from the quality of life than anything that's not a stress-related disorder? For those of you who are technicians and not therapists, go to Wikipedia and look up stress-related disorders. Beautiful list of everything on that list is what the alpha theta sessions help with pretty much exclusively. And the other protocols can take some of the edge off of that, but aren't going to have that big of an impact on it. So it's is a stress-related disorder detracting more from the quality of their life than anything else. We do have one other thing when we're talking about this: under-arousal, over-arousal, or stress-related disorder. There are the bipolar disorders where people swing between highs and lows. That is the only population that if someone has a particular disorder, that we indicate that to the software, and the software, no matter what else you tell it in the assessment tool, it's going to give them this nonlinear protocol. And that's the thing too, when I said that if you have anybody with moderate to severe bipolar disorders where they're having auditory or visual hallucinations, paranoia, what have you, the more severe they are, the better the candidate they are. That particular approach, when they're moderate to severe, during the first session, they feel their mind and bodies quieting down. And it's the only population that during eyes open only training, they feel the real effects. Most people will feel the opposite effects. It's training them to wake up or slow down. They feel more spacey and bored because their brain gets tired and they want to get up and do something because it's a brain workout. But that's a population where they tend to feel the real effects. Moderate to severe bipolar disorders. They swing back and forth. And it's the only population, if somebody has it, that the software will handle that for you and give you the nonlinear protocol. Even if you forgot it, when we teach you how to do the assessment tool, it will come up with that for them. Okay, so those are the sort of like 4 training strategies. When it comes to the people who anything but a stress-related disorder is detracting most from the quality of their life. When it's anything but that, the training will be an eyes open only protocol, and and everything with that's the alpha theta. It will be everything else. So there's like 4 different training strategies with this nonlinear is only for that population with bipolar disorders. There's another question too of people, usually if they haven't been diagnosed with a bipolar disorder, there's a question about multiple chemical sensitivities that would also be interesting. We'll get to that later too, but there's essentially 2 populations that would need to start out with this nonlinear protocol. But when we do the assessment tool, as I'm going to teach you, you can't miss it. All right. So alpha theta sessions, what they do, it always has to be done with the eyes closed or it will not work. There's either a guided visualization or a systematic desensitization method BrainPaint delivers with you for the client to get them to not react while they have their eyes closed. A lot of people with moderate to severe PTSD, when they close their eyes, they see bloody faces, terrible things, they dissociate and do all this other stuff. The software with the assessment tool, which we'll teach you how to use, will give you an intervention when that's going to be the case and give them just a 7-minute protocol with this distraction exercise. Other than that, we will give them a guided visualization. that it will walk them through systematically some things that will trigger their amygdala a little bit to respond and then extinguish some conditioned effects in their amygdalas during the alpha theta sessions. So there's one type of training that can help with more of the organic aspect of issues if one's brain is stuck in underactivation with depression or overactivation and other types of anxieties that are not PTSD. And then there's the stress-related disorders, insecurities, PTSD, phobias, things of that nature that the alpha theta helps with exclusively. And when people have both, never a problem. The software will tend to zero in, the assessment tool will tend to zero in on what's going to give them the quickest, most predictable results. And in some cases, the software knows that some people will need one type of training before they do another. So you'll have some people, there's no question whatsoever that they need the alpha theta training. The software does a beautiful job, way better than I can, at identifying people who should not start with the alpha theta training because it would slow them down too much. And so sometimes it will come up with this eyes open only protocol for them. And yeah. So that is that. So there's only two things you have to teach them to do during the feedbacks or during the alpha theta sessions: have their eyes closed and respond to some things that either that you're telling them to do or the machine is telling them to do. That's alpha theta. And then everything else is this eyes closed, eyes open training where they look at the screen, at anything they like on the screen, and when they see any blue in this what is and graph, they click the right mouse button. At the very end of the day, I'll walk you through the two types of training at the very, very end of the day. What to tell a client to do during the two types of training. Christina, go ahead.
What happens if they fall asleep?
You know what? I'm going to cover that right now because it's very important. During the eyes open training, you handle it like this. You'd say, okay, client, when you saw that they were sleeping. Being sleepy is not a problem. So during the eyes open training, more people would fall asleep during the eyes open training than they do the eyes closed training because it's a brain workout during the eyes open training. And so when they're sleeping, not just this is fairly common during the eyes open training. If somebody's kind of like going like this and then they catch themselves, never a problem. I would not do what I'm about to do. But if their head slumped to one side and their eyes are closed during the eyes open training, and say, okay, Jim, there's a little button here. It says pause, unpause on the feedback screen. Boom. I click that and say, hey, Jim, we're going to have you finish the session standing up. And your next 3 sessions, we're also going to teach you, we're going to have you starting them standing up. Oh, no, I'll be fine. Jim will always say, oh, I'll be fine. I'll be fine. No, don't worry about that. I'll be fine. No, we can't. Because every second you're sleeping, Jim, you're getting conditioned to sleep more. And so we have to intervene with that now. I'm sorry. I understand it's uncomfortable. It's more comfortable to just kind of sit in the chair and do it. But this is how we got to do it. And so, all right. So then they comply. So you just have them stand up. If they can get behind the chair, we have them do it. Otherwise, you just tilt the screen down like that. You just have them stand and look at the screen. Again, you'd finish the remainder of the session where they were sleeping, and the next 3 sessions just have them do them standing up. That conditions them to remain awake. During the alpha theta sessions, when you see that someone is sleeping, as evidenced usually by snoring or the head slumped to one side, their mouth is open, or the feedback ends and it goes, okay, slowly start bringing yourself on back now, and they're still just sitting there. That's definitely sleeping there. I'd say, hey, Jim, we're going to move you to this little stool with a 6-inch backrest and have you finish the remainder of this session in this stool and have you do your next 3 sessions in it. And what that does, there's a part of our brain called the reticular activating system that keeps us alive. If a smoke alarm goes off while we're sleeping, or a baby has a certain type of a cry, it'll alert us and we'll go and take care of it. Well, when they're sitting in one of those like folding metal chairs, for example, that you see in conference rooms, are often beige colored. Those are the best. You can set them anywhere in a room or what have you. If somebody's sleeping in the alpha theta session, you just take out that chair, walk them over. You can unplug the amplifier cable from the box, have them walk over, plug it back in, and say, okay, now we're going to finish it in this chair. And you do the remainder of the session in that chair in the next 3 sessions, and that conditions them to stay awake. What is the most intuitive but wrong thing to do is to go, yeah, that'll work 100% of the time, once, twice, possibly 3 times. After that, you could be sitting there shaking their chair and they'll be out cold. That doesn't work. Or making aversive sounds that would honk to alert them. Doesn't work. We tried it. Yeah. That what happens then is their brain goes, oh, someone else is managing this and I don't have to. But when we have them sitting in that chair, it engages that reticular activating system. One more quick tip you can do for that. This is also in our 2005 publication, that you could tell the person not to wake them up. I'm not going to say this to wake you up, client, just to confirm that you're too deep to get results with your alpha theta session. I'll say 2 words in this very specific sequence. It's going to start out with the side and then the limb. So left side, I'm sorry, left hand, left foot or right hand. And whatever limb you thought you heard me say, move that particular limb. So if they're too deep to get results, they won't hear the first limb that you said, left or right, for certain. And they won't move at all, or they'll move the wrong limb, or they'll move the wrong side, or what have you. They won't respond. And then we go, okay, we know then they're too deep to get results because their brain can't hear you say the side first and then which particular limb. They're too deep to get results. What happens when they cross a certain threshold of sleep, their brain can't hear the external world unless there's these kind of danger signals happening. They won't. So that's how you can be 100% certain someone might be sleeping in their session. But also it doesn't work if they're sleeping in their sessions with alpha theta. And now the software will take a case note where it will say, hey, 20% of the time there's nothing to worry about. Someone just has a thicker skull than the average person. But there's an 80% chance Jim was sleeping in this session to the point that he's may not be achieving results. It'll type out this long case note about that. It'll save it in their client file. We'll get more into the client files next week, but that will save a case note. It'll type it out on a screen. You can't miss it after their alpha theta session. And but you can see that there. Did you have another question, Chris?
Yeah, you mentioned fire alarm, and it made me think we had a fire alarm go off in the building while someone was doing neurofeedback. So I was curious, how, does that have any impact?
Well, it would affect that particular session, but anything that will affect more than 3 minutes of the session, like if somebody had their eyes open for 3 or more minutes, or a sensor fell off their head for 3 or more minutes, or someone was having a hot flash for 3 or more minutes, the EEG signal just goes all over the screen while they're still. 3 or more minutes tends to be a threshold where it could start to have an impact on their session. It's not going to cause any, in something like that, it's not going to cause any negative reactions. If a sensor fell off of someone's head for 3 or more minutes and there wasn't somebody monitoring the process, they would likely have some negative reactions if just one sensor came off and the other was left on.
So in that situation, it wasn't a drill, it was like an actual fire alarm. So they had to stop and go outside and all that. So how would you just go back in and finish? Would you restart?
Yeah, definitely. Another thing too that would happen if someone's not monitoring the sessions around the first of the month, Microsoft forces these updates and it says, hey, we have an update. Do you want to delay this or do you want to do it now? And we'll give them like 30 seconds of a countdown. If nobody sees it, the computer will just restart itself. Wherever they were, you could just go back and run the remaining protocols that they had that day. Similarly, if they had to leave. But if somebody's monitoring the process, which they should be, monitoring it for when a sensor comes off or things, that also has a big impact on client retention, then you could prevent that from happening, or you just hook them back up. I'll show you right now. For these gray cables, we can just unplug them from the amplifier. So they're plugged in like this. This is the sensor cable. So it's plugged in like that. If somebody had to go for a fire alarm or go to the bathroom or something like that, you could unplug this, wrap it around their neck. If they're okay with that, let them go take care of business. And when they come back in, you'd put it in and then you'd confirm if all lights were flashing yellow or flashing green still, they would be good to go. Or if the sensor came off, you just reapply that sensor. But usually they don't come off. Even with the kids, who we did this in a nonprofit clinic for over 2,000 of them for 12 years. Even with them, when they had to go to the bathroom, they would rarely knock the sensors off their heads. They were all 5 to 11-year-olds in five elementary schools in the LA school district. All right, so that is alpha theta and how to handle sleep. That is a big deal if people do fall asleep. Also, among the 10 people we've identified from, who had died from relapse-related deaths, there were at least 2 of them who the software had suggested they were probably sleeping in their sessions as well. So that could be deadly in that case. Okay. So those are the 3 types of training. How do we come up with these protocols? That's the easy part. That's next. Something too that I can't stress enough. Often, in institutions, everyone wants to do things in a very, the most efficient ways. You have all these systems that you do things in, and when you want to streamline something, don't make things up for that. Check in with me on it so we can know exactly what will work or what would diminish or eliminate results for that matter. Like one thing that's not intuitive, sometimes people go, we're going to give this kid 15-minute protocols. Wouldn't you assume that if half of a protocol would be half as effective? It would be a natural assumption. It isn't, though. It's only about 25% of effective, and virtually no one who does that will stick with the process long enough to get results. We'll cover more on that next week. So there's a million things like that, but if we just do what we're covering today, with it, it's easy. And there are some ways we can experience, like most of our institutions have multiple machines that they run simultaneously as well. And there's some things that we can help you with that too, there is a way that we can get a lot of your sessions down to just like 24 minutes in length and not have to move the sensors multiple times. There's things that we can do that we've demonstrated through the scientific method in clinical trials to show that they're efficacious as well, and saving some time also. All right. So there is that. The assessment tool. So what is that? Okay, I'm going to my computer screen's going to blow up in a bit here. So why don't we all let's take a 5-minute break. But when we come back, let's get your brainwave amplifier like this, and we'll plug it into it's a USB cable. You'll find that in your kit. Just plug in the amplifier. Don't worry about this gray cable yet, plugging that in. We'll get to it. No, don't worry about the sensors or anything else. But when we come back, I'm going to have everyone turn on your computers and go through the assessment, part of the assessment process with me. So on my clock here, let's make it come back at 40 minutes after the hour. Make it 6 minutes, 40 minutes after the hour. Yeah, I'll plug your computers into a power source as well. Yeah. All of these food and steam. Oh, hey, Elise, I just noticed I have to get back to the court. Could you, I can't find I don't see anything about cleanups in the email subjects. Okay, yeah, yeah. Okay, yeah, please do that. If we could put texting me with critical things. I thought that Zena was handling all, she's confident that all the problems for her. So anyway, okay, got it. I understand. All right, I'll call you later. Bye. Welcome back, everyone. So to run BrainPaint on your desktop, you'll only have 3 icons that will look like this. You have a BrainPaint icon, you have your tech support icon, and we have the BrainPrint icon. We're covering that on training day 3. We also have this team viewer icon. That's for clinicians to log into your computer. That about every 6 to 9 months, we have to do some maintenance on your computer to keep everything working well. And that can usually happen when you have a break in the action of like a half hour. But you just run this tech support icon. If ever there's something you can't do with your computer, you can just run that tech support icon. If the computer won't turn on, which happens occasionally, there's a sticker on the laptop. You call that during our business hours. We resolve that usually within 15 minutes. Or on the BrainPaint app that you all put on the home screens of your computer as well. You can contact us easily through that. It'll show you who's on staff for technical things. But to run BrainPaint, there's the BrainPaint icon. Go ahead and put your mouse over that and click twice fast. Like click, like that. So if most of you are probably Apple users, but it's 2 left clicks of the left mouse button. And also only plug the mouse into that we sent you that comes with it. It's this Amazon basic, they're awesome little mice. Plug that and get used to using that, because if you're all Apple users, you're used to the best trackpad in the world, and these are different. So if you use a mouse, it will be much more intuitive. Otherwise, you'll be clicking on wrong things and stuff like that, perhaps. So yeah, using the external USB mouse. Also, we highly recommend not, connecting anything else to it that are not USB powered, no wireless things. Those can interfere with signals. When it comes to headphones, we highly recommend do not use headphones unless you have to have multiple machines in one room. If you have to have conversations in the room someone is in, don't use headphones. It will not work any better. And it will just have more moving parts and more things that will break. And the sound, if you're plugging them in and out, the computers will lose connectivity with the sound and things like that also. And if you do use headphones when you get multiple machines, then get one with its own little volume control, but no electronics in it, no battery, anything, no noise cancellation. All of that will produce signals that will interfere with the signal. Just a basic, they're called 3.5 millimeter jacks. Every laptop you have has those. But again, we highly recommend against it. You do not need this perfectly pristine, quiet atmosphere. You could have people periodically laughing, walking by the room, or the cleaners in the evening banging the walls with a vacuum cleaner. And one other thing about that, which is good to know, that if you're concerned that that's going to disrupt all of your client sessions, your clients will be concerned that that's going to disrupt all of their sessions. And they'll make it a big problem that you're experiencing with that. That is a very valuable thing to know about this. For 2 years, I had an office on a terracotta tile floor where carts were wheeled by all day. I was on a mission. I was going to get them to go this other longer route around, putting up signs, everything. While I was in battle with them, all of my clients were in battle with them as well. Soon as I surrendered, there wasn't anything I could do about it. Never had a client have a problem with that again afterward. That is something that's invaluable to know. You get to see transference so instantly with this technology and the power of transference, positive and negative for that matter. All right, so that is it. So when we double left click the BrainPaint icon, it brings up, this is the BrainPaint program. And we don't have a client to start a session with yet, per se. So we're going to click on the new evaluation. We only do this once per client. We click the new evaluation button, and that brings up this little screen where we'll get some information on what we call growth areas, some basic demographic information, first name, last name, initials. We're not aware of any any security breaches getting into the equipment, but if we don't put any identifiable information into the machine, none could ever be taken out. So what a lot of people will do so they can identify it themselves is they'll put in like a first name like Bill, last name, they'll put in an initial and then maybe something like S and like 05 2025, something like that, an age and a gender. This other information is not necessary, but what is really helpful for clients and you to see progress really quickly is to create quantifiable goals. And who here has a client who does not have OCD or significant incessant repetitive negative thoughts, obsessiveness, and does not have a character disorder that you're thinking about this with? Who here has someone like that on your caseload that you're thinking about doing this with? How about you, Tiffany? What group do you work with, Tiffany? Can you unmute yourself for a moment?
I work with IHR in Illinois, Pontiac, Illinois.
IHR stands for, what does it
The
say?
Institute for Human Resources.
Got it. Very good. In Illinois. All right. And do you have a client in mind who you're wanting to do BrainPaint with right now?
I initially have an OCD one, so I'll skip him. I have a client who has some alcohol addiction and severe anxiety.
Okay. And the alcohol addiction, are they currently involved in an already effective treatment for the addiction?
No.
They're not. Okay. Because we can get rid of a lot of comorbidities with it, but that's not likely to get better when they're not good. Even if they were going to 12-step meetings or smart recovery or AA, NA, any of the above, we could be helpful for that, but it's not a standalone treatment for addiction, unfortunately. That's all process addiction, sex addiction, video game, media. Yeah, it's not a standalone treatment. When it's combined with it, that's when we see those effects. Who else do you have?
Of course, I've got difficult. I do have one who I believe she's bipolar with PTSD.
Nice. All right. So what I'm going to do here, let's do an experiment here. What we want is a growth area that is a growth area, a goal where there would be some behavioral outcome of the emotional or a behavioral outcome of the cognitive issue that we'd see on a video camera without words. So with this client, how would you think of them in terms of like, what would we see? How would we know we're making progress with this client?
I know that she has a lot of reoccurrence, like in night terrors and things like that. So reduction in night terrors.
Yes, has night terrors, and that will tend to be the first thing we'll see impacted by this work as well. Client has night terrors, And also mood swings from the bipolar disorder.
Yep.
Well, okay. So we'll make that a separate growth area. So client has night terrors. What I'm doing here initially is I'm going to test out this AI thing that I just created as a model. And then, so the other one is bipolar symptoms. And where would we see result? What is the frequency, duration, and or intensity of the bipolar symptoms?
Goodness, I feel like I'm back in psychology. I know that we have a lot of crying spells.
All right.
So I would assume like reduction in crying spells or like reduction in number of them.
All right. So here's what I want to do. I'm gonna give you all this thing here in the chat feature as well. Well, I actually have it saved in the slides too. So I'll give you a copy of the slides that you can copy this particular kind of pre-training AI model. Do any of you use like ChatGPT or any AI models? Do you use those ever, Tiffany? Yeah, almost
I
every.
use them and so do my clients with OCD.
Nice, very nice, beautiful. So I'm going to give you some text as a prompt that will do this here. Okay, so I just copied this particular growth area, which you could, after I give you this thing here, you could just type these in yourself. Where's my question for this one? Okay, there we go. So I'm just putting in the growth area here. When we're done with this, let's see, just paste. Oh, okay, I have to copy it again. All right, so I just put in that growth area. It's done in a very vague way right now. Client has bipolar symptoms which bring on crying spells. Like there's nothing really quantifiable about that yet. With this thing that I gave that I'll give you the text to, this is what it should do. Where it's so it gave us the category and the analysis, and then here's a probing question: how often do crying spells occur weekly, and do they lead to actions like withdrawing from work, school, or social events? Do coworkers, friends, or partners express concern or notice your absence during these episodes? And here's an example of how it made this growth area for us, where it says bipolar symptoms, and then it puts a colon after it. If we put a colon after it, BrainPaint will recognize that it's a BrainPaint will recognize that that's the category. And here's what it said: crying spells 2 to 3 times weekly, leading to withdrawal from work, social interactions 1 to 2 times weekly, with occasional concerns from coworkers. So how about we answer these questions here about the specific client? It's asking some. And it's, yeah, what do you happen to know about the frequency of the crying spells or any of this?
So it would be like crying spells. It's asking for weekly, so I would say like 5 times weekly.
Okay.
And they do lead to withdrawal from social events.
And they. All right, so we'll put that in, and now the AI should rewrite this in okay, so it rewrote it now in a quantifiable way. Bipolar symptoms, crying spells 5 times weekly, leading to withdrawal from 2 to 3 social event tasks or work tasks weekly. That's probably not all true, is it? This last piece, 2 to 3 of those weeks?
Not 100%. Like you said, the friend or coworker expressing concern, like she's pretty withdrawn.
I understand. Yep, I understand. So we can put them in here like this. It got the heart of it though, like the 2 to 3 times a week. We could just erase the others. So I'm going to give you all this in this new these training slides in the chat feature. Where are we here? Yeah, that's very helpful. I'll likely be able to integrate this with a full update, with a BrainPaint update that comes in to your machine. And when you type it in here, it would say, hey, do you want me to revise that? That doesn't look identifiable enough. You want some help with that? And then it will engage in some dialogue with it. All right, so here's what that looks like. Okay, so here is the training slides. I have it under types of assessments. Okay, so this is the slide. So the text is very small here, but you don't really even have to read it. You can just copy this and paste it in your AI model choice, and then just start writing growth areas, and it will rewrite them in this format that we want. But we'll pay attention to the that there has a colon after it. If you don't put in a colon when you open BrainPaint up, it'll say, hey, categorize this growth area, and it will do it 4 times for each growth area that doesn't have a colon written after the growth area. All right, so there, I will put that in a moment in the chat feature. We're going to put this one in it now too. We'll test it on the first one with the growth areas here. Also, all right, so this is one we just put in here. Client has night terrors, and we'll see what it does. It's very vague, but the AI model in my tests were doing a good job. Night terrors, experiences night terrors 2 to 3 times weekly, causing 1 to 2 instances of daytime fatigue or tardiness at work, noticed by coworkers or what have you. So we can just copy this like this and then paste it. What I would do is I would do this on like a mobile app or something. And then when it wrote it out, then I would just type it in here for the time being, and then just modify it to what it actually works with. You know, it results in like a daily fatigue would almost for certain be the case. And this would be an awesome candidate to start out. Because also too, when people have nightmares at night, they always have daymares during the day. When their brain starts to get into some of the slower states, that's when more of that stuff would tend to come on. And we always want to create, when you have somebody who has nightmares, let's always create a growth area around the nightmares, because will correlate with a ton of other cognitive and emotional issues that are getting better as the nightmares are getting better. So here comes I'm going to put that in the chat feature right now. Here come the slides. Yep. All right, that is to everyone. It's on its way. That will be in the chat feature in a moment. Okay, so those are the growth areas. Another thing we have are these. We have these growth, above each growth area, we have a menu of options that we can help you pick from somebody. So these ones that say behavior, they're not behavioral issues. They're actually the behavioral outcome of emotional issues. And these top 3 will capture almost everything for anyone you'll be seeing, where it says, at least twice per week, I end up crying over something. That is a modifiable goal, that it's something that people will remember. Or at least twice per week, I end up raising my voice over something. That also is very quantifiable. The thing about the emotions, where it's like, oh, I feel depressed at least twice a day, or I feel anxious twice a day or 5 times a week. The thing about emotions are not quantifiable. When they're in the emotions, then they don't have any time. There's no time that exists in them. They can't really count the frequency, but they will all be able to track the behavioral outcomes, the patterns that happen after them. Panic attacks are different like that. When people's hearts are actually racing, And also in the addiction treatment centers, we see 50% of all the BrainPaint clients have panic attacks. Their hearts are racing. They feel like they have to rush out of some place or things like that. Those, even though they're emotional, those are like getting hit with a cattle prod. You're not going to forget that when that happens on a day or how many times a day. So those are easy to count when it comes to panic. Like that, and respond really well. And it's a really easy growth area to create with people in addiction treatment centers because 50% of them will have them as well. But so I clicked on the growth area help. It brings up these different options like this. When we just double left click one, like this one here, I shut down for at least 4 hours, where I isolate and offer minimal responses if need be. You just double left click it, it said, and then it puts it in the growth area like that. And we can scroll down on this page too with your mouse's scroll wheel to see different categories. Ooh, anger. Oh, panic, sleep, night terrors, nightmares, fatigue, mood swings, obsessionality, seizures. Yeah, there's lots in here that we can pick from also. Sometimes people wonder, why don't you put these in the positive, that where we're going to end up? And the reason is that people tend to only notice when the problems are present, and we can tell when something's getting better more quickly when it's actually in the negative. And being that we're not kind of just trying to hypnotize people or get them to believe they're going to get better so that they do get better, it isn't part of that. We actually see the real symptom reduction happening like that pretty rapidly within 5 to 8 bi-weekly sessions, or 10 to 12 if once per week. So putting them in the negative will help us see where the problem currently is and how quickly it's getting better. Okay, I'm going to leave one growth area blank here to explain something on the next page. All right, so I'm going to hit my next button here. Your computer won't say this. All right, so this is the evaluation tool. This is where the rubber meets the road in terms of what protocols does the software come up with for it. The most important rule with this is that we just mouse over each item like this. And notice this one just has one question. This one here happens to specify a certain frequency per month that something's happening, but it's still one question. This one here has 2 questions, okay? So the rule with the assessment tool, probably the most valuable rule with the assessment tool, is when you mouse over an item, if there's 2 questions, a yes is always a yes, is the most important rule. So if somebody says yes to the first option, you click the box. And you do not ask the second sub-question. So does Bill's speech seem slower than the average person? Something you can assess here. It's like, yeah, his words are a little slower. So then you click the box and you don't ask it. But if it was no, Bill's speech seems actually faster than the average person, or it seems average, what have you, then you have to ask the next question, or you will not get an adequate evaluation. And notice too, the questions don't appear that related. Doesn't matter. Does it seem to take him more time to respond to questions? So then it's like, if it's a yes, we click it. Something about that, some of these have multiple questions, like this item down here about caffeine. This, I would say, is the most valuable question in the entire assessment. That when it's checked, it writes an entire book of what all the other items mean about everything else. Or when it's not checked, it means even more information about everything in the assessment. But notice how there's, there's 5 questions with this one. So if somebody endorses the first one, we just click it. But notice the bottom question down there says, check this item if you get there. Check this item if the client has never ingested caffeine. So the other thing too is the words in here. are very specific as well. It's not saying drinking coffee, it's in any form. So if somebody drinks green tea, for example, like here's a common mistake people can sometimes make because these questions are so literal. That's what I just wanted to drive home. You don't have to read through any lines with them. But do you consume caffeine in any form 3 or more times per month? So a common answer will be a client will say, yeah, I drink, green tea at, restaurants, but I don't I don't drink coffee or anything. Was that a yes or is that a no? There's caffeine in green tea. Is it 3 or more times per month? Yes or no? That would be a yes, regardless of they're saying, or yes, but if I drink more, I don't like it or what have you. We have another question on that. So that's the thing that we just have to be mindful about. The questions are phrased in very specific ways. And let's not do a shortcut when it comes to these. Like what a mistake people will make with one, and then the assessments get off and people start having negative reactions. And the only time now that people have negative reactions with is when we're not doing the assessment tool correctly, or we're getting answers from an adolescent or a child who's not capable of answering these other responses since the last session, which we'll be covering next week with working with kids. We used to never be able to, I used to never be able to answer clinical questions via email. But in the last 2 years, if you have a client who's not responding really well, I can shoot you an email and give you 3 of these questions that you made a mistake with. And it's like, goodness, you're right. Their eyes are more closed than the average person. I didn't check that. Or, yes, you're right. The about caffeine item isn't checked. And I can see now that it should have been checked. Or this mood/sensitivity item isn't checked when it should have been checked. Those are 3 items that people, if they don't do the assessment as I've already taught you, then people will have some negative reactions to the training. Like that. And when I say a negative reaction, what do I mean by that? Are they growing antlers? No. Are they getting hospitalized? Never. What it is that they'll never have any issues coming up that don't come up once in a while anyway. They'll just have more of them coming up. In fact, if we did not ask them about it, they wouldn't even notice that it was taking them an extra 15 minutes to fall asleep, or they're gripping their steering wheel till their hands are more tight and their body's a little more tight than usual. A couple days after a session, that is 3 days absolute max after a session. But again, they'd be very subtle things that happen once in a while anyway. They would just be a pattern that would start to emerge after the sessions. We'll cover a lot more on that next week. But when we just do the assessment exactly as we're talking about here, we just mouse over the items, yes or no. Do you space out even with things you're interested in? So do you? They would say, well, I have done that. Is that a do you? No, it doesn't care if you have. Everyone has. We've been tired or what have you. But do you? So the follow-up question would be, which is here in the evaluations box, a reminder of how do I do this? If somebody says, for example, with this one, do you space out even with things you're interested in? Sometimes, how do I handle that? Well, you have a reminder here in this evaluation essentials. If ever you're wondering, I'm not sure, that's not a yes, it's not a no. Here they're categorized in the most common ones. Like questions like, do you blank out? Should only be checked if the client has a pattern that's significantly detracting from the quality of one's life. When someone answers sometimes, we follow up with, would your quality of life be clearly enhanced if you did less of this? And when they say yes, we check that item. If they say no, not really, that's not a yes. We would not check it. So this will happen a lot with your obsessive people. They'll keep saying sometimes. It's like, would your life be better if you did less? So that's another thing too, that you're sparing yourself some time. When you're new with this, they'll go all over the place with the assessment, as they do with everything in life, before we have an effect on their yet untreated symptoms. Okay. So those are 2 items. So that thing I was talking about earlier too, about the the trauma drama, do you have PTSD? Like I said, the software doesn't care if they have it. It wants to know, do you, the clinician, or your clinical team, in the case of technicians who are doing the evaluations as well, does your clinical team and or you as an individual therapist think that the PTSD is detracting more from the quality of life? So here's the question. And yeah, and we never want to take, client's own verbatim answers. That's another evaluation essential, is it says never ask the questions. Always use your own observations of a client's reported answer over anything any client ever reports. And so there's a phenomenon here where people's brains tend to be stuck in these more over-aroused areas where they have agitation and irritability and aggressiveness. They tend to lack tremendous insight. And they will never see that they're aggressive or agitated and things of that nature. They'll go, no, everyone around me is an asshole. That's why I react like I do. And when they start behaving, well, I'll be better. So almost all adolescents, they anybody for that matter, they can't really see that stuff. But that will usually evidence itself by the voicemail that they left you inquiring about the service, or in creating the quantifiable goals on the previous screen. Those will evidence themselves usually during the course of it. But that's important to never ask any questions the answers to. I actually did a study where I let lay people who had never done this before, who were also very biased friends, who were not therapists, do the assessment on themselves, and then I did an assessment on them later, and it wasn't enough information to get an adequate assessment. We could have 20% wrong answers in the assessment tool minus the caffeine and bipolar disorder item, and it'll still come up with a good enough starting point, but lay people can't. So you can also, in the evaluation assessment, we can never allow a client to answer their own evaluation questions. We know that will not work. And another thing too about all evaluations, when people are not asked each question, you're getting a response, they have significantly less accurate responses when people read any instruments on their own. Another evaluation essential that we really have to be mindful about when you've done a bunch of these, for example, is it's never read the question headings. When you've done a bunch of these, it's an easy mistake to make. Like an example is when you've done a bunch of these evaluations, you see that these are all about liking caffeine. But if you ask someone, do you like caffeine? You're not going to get an accurate answer to this question. It'll steer it the wrong way way too frequently. Similarly, this item over here, most of the time when you check this box, it's going to be when people have a bipolar disorder. When you've done that 5 or 6 times, after a while, people will just start going, oh, do you have a bipolar disorder? No. Then they move on. That's a mistake. Why is that a mistake? Why would that be a mistake if they said they didn't have a bipolar disorder? So let's check this box if the client has a bipolar disorder, regardless of how well their symptoms are currently managed. This ensures a client will start with the nonlinear protocol. Okay, so you're asking, do you have a bipolar disorder? No. So if they say no to that in the evaluation essentials, then we have to ask the next question. Have you tried medications, psychiatric or not, 4 or more times and had more negative reactions than benefits? So they might say, yeah, I tried antidepressants once. Yeah, and Benadryl. Oh my God, this happens. Oh yeah, and I tried Ambien once, and this happened. Let's see, is there a fourth? Yeah, I took Tylenol once, and I couldn't sleep, or I was getting hives and things of that nature. So 4. So if they've tried medications of any kind 4 or more times and had more negative reactions than benefits, we also have to check this box. And this comes up with the nonlinear protocol for these people. Often they'll be close to being diagnosed, or they're too young to be diagnosed with a bipolar disorder, but they'll be too sensitive to the regular training strategies initially. So when this brings on that nonlinear protocol, this first teaches their brains to stabilize states, because their states get knocked around too much by their own emotional dysregulation, and their PTSD and their obsessionality and external events and even cycles of chemicals and things of that nature. So it gives them this initial training strategy that first just teaches them to stabilize states. I can almost see this as a teeter-totter in the light teeter-totter in the wind that's just sitting there. You know, if it was like this light plastic, it's in the wind and it's balanced perfectly. When any wind blows from this direction, it's going to start leaning that way. It's blowing from the other direction, it starts leaning that way. What we do, if you widen the base of that teeter-totter when it's on, a lot more wind it would take to blow it. It's not going to be just moving in this direction or that direction. It stabilizes their underlying states with this nonlinear protocol. And it's the only issue where there's a protocol we always need to start people out with. And the software will handle it simply by asking each of the questions like this. And if they say yes, we click it and we move to the next item. Any questions about, some of the chat questions came in. That's the thing with this feature. The chat questions don't come in very well. Please send a link again. We had to join a computer. Yes, no problem. I'll put the link what you're referring to as a link. Oh, is it the Synchrony? I'll send the Synchrony app link and the training slides again, because someone had to log out and come back in.
I think other peers already sent the slides, so I think we're okay now. Thank you.
Okay, no worries. I'll put them in again. There was somebody who came in later as well here. Take long.
I also ask a error user over here. I did not have your screen up because on the top of your Zoom, it says that you can switch back and forth. And I'd never even seen that before whenever I do Zoom. So I was not watching your screen when you put in the growth area. So I missed what we put in there. So if we need to put that in there, I'll need that information again, please.
Okay, got it. All right, I will circle back to it. But now can you see my screen okay?
Yes, I found the link up there. It says it at the top of the Zoom, like you can go back and forth between just seeing your picture and your screen. So it's there. It just wasn't there whenever I came back and entered back after our 5-minute break. I don't know why my Zoom did that.
Oh, I see. Got it. All right, I will circle back around to that screen once we finish the evaluation tool. Yeah, thanks. Let's see if the other questions came in. Zoom growth areas. Yeah. All right, cool. Can you please send the link again? Yes. All right, so there we go. For those of you who came in late to that, BrainPaint app is an invaluable tool for connecting with us. It has all of our services. We recommend installing it to the home screen of your mobile device. It won't work on a desktop computers, Apples or PCs, only on mobile devices, on an Android or iPhones. There's a little thing. It walks you through how to install it on your, there's a share button on it's a web browser. There's a share button on it. When you hit the share, there's options. You can scroll to say save to your home screen, and then it will save a little icon on the desktop. And then whenever we update it, you automatically have the update as we add more smarts to it and stuff like that. All right, so another item in the assessment tool where the software wants you to give your best estimate on what do you think yes or no is a stress-related disorder appearing to be detracting most from the quality of their life. Not do they have one. It doesn't care at all if they have one or how horrible their trauma history was. That's not helpful for the software to come up with the best training strategy. But do you think that's detracting more from the quality of life than anything that's not a stress-related disorder? That's what this item here is about. And it says, do you think the primary issues that are now most detracting from Bill's quality of life or performance, they seem to start after scary events? So do the primary issues that are now most detracting from Bill's quality of life or performance seem to start after scary events? Yeah, most attracting, not does he have them. That's a thing that will take some time to kind of unlearn. Because you're used to looking, do you have this symptom or that symptom? Like an example, everybody with traumatic brain injury, if you ask them, is the trauma of your brain damage detracting more from the quality of your life than the brain damage itself? Every one of them would say, yes, yes, I stand to have to live, getting used to this whole new world, this whole new brain. Yes, that's the worst thing. It isn't. It isn't the worst. They're not being able to talk or swallow or things of that nature, or move or see or smell. That is always detracting. The individual will think, but no, if you could only help them with just their PTSD and leave them wheelchair bound for the rest of their lives, or stuck in these other horrible reactive states, that when it's right hemispheric brain damage, they all are just the most miserable people you'll ever know. Maybe not as miserable as people with psychotic features, but extremely miserable with right hemispheric damage. The individual will always say it's their PTSD, and it clearly is not in those cases. That yes, they have it, and nowadays too, everybody kind of frames everything as PTSD is the only problem. 20 years ago, everything was depression, and Prozac was the only solution. Okay. So it's what's detracting most of the quality of their life. It phrases it in some different ways. So if it was like, oh, I'm not so sure about that it seemed to start after scary events. So then there's another question we would have to ask. Do the primary issues that are out detracting from Bill's quality of life or performance primarily come on when he's in specific situations or relationships? Yeah, that's it. When a helicopter flies overhead, like ducking for cover and looking for a place to hide, my heart's racing and all of that. That's like a really extreme example of it. But if any issues is coming and going, like the weather, like depression and or generalized anxiety or other issues, or it's a cognitive issue where they're about to walk out in front of traffic, for example, because they're just so unfocused, that would not be the case for that. Then these items here, another mistake sometimes people will make is they will think that the question's asking, do you have any of these 11 items? It is not asking. It doesn't care. It wouldn't be helpful to know if they had them. What would be very helpful is, would Bill's quality of life be most enhanced by improving any of the following 11 items? Be most enhanced. And so here, this would be if you were thinking it, you weren't sure about the trauma drama item, because we have to pick one or the other. When we pick this one, it deselects the one above. And so we have to give it our best choice. But here we can inquire about this. If it was an adolescent, anyone who's 17 years old and under, I highly recommend just doing the entire evaluation without the kid even being there. Yeah, 17 years old and under, do the entire thing with a parent. These can help clarify that. And in cases where you're not sure of which is which, it seems very 50-50, that is never a problem. That the software does a much better job even than I can. When I give it my best estimate, I need to pick one or the other, but then the software might not come up with it. Like I mentioned briefly, anybody who has major depressive symptoms and PTSD, a lot of them, not all, but a lot of them, I would say over 50%, it will not give you alpha theta sessions. It knows that what would happen if we did, because it's worked on tens of thousands of people who built the model that BrainPaint works with. Didn't respond well when they started out with alpha theta, that particular population. So don't get too married to it coming up with that, which is another easy thing to do, particularly those of you in the institutions where 50% of your people have panic attacks. A large percentage of them, 70%, are going to be starting with the alpha theta. And you'll see all these miraculous things happening so quickly because PTSD tends to be one of the most challenging issues that someone has. And when they're doing this, that's going away so quickly. Don't get too married to a particular protocol for everybody across the board. When it comes up with it for people, that is the best thing since sliced bread in my observations and opinion. But yeah, don't try tweaking things to make it do other things, or you'll start having clients having negative reactions. Okay, so there's different ways that it asks about the issues are more biologic in nature. It's like, nope, none of those. We're detecting more from the quality of their life. Then we would ask, have you had a clear positive response from antidepressants, mood stabilizers, antipsychotics for issues you most desire EEG biofeedback to help you with? So do not check this if the client is referring to tranquilizers like benzodiazepines, street drugs, alcohol, or beta blockers that have helped with refractory forms of depression. Has that happened? It's like, yes, I've had a positive effect of things that I'm still wanting help with, but I need more of an impact on it. That's what that would essentially be. There you'd click it. And so, yeah, those are the trauma drama, or issues are more biologic in nature. There's another thing, it won't let you do something here too. Like if this issues are more biologic in nature, it won't even let you pick this item down here that they primarily want to overcome fears. That this item will clarify when you have the issues are primarily trauma or drama related, about 80% of the time, this item here will also be addressed. So the software, it helps the software sometimes identify some discrepancies or the thoroughness with which one was doing the evaluation process as well. But usually, like I said, 80% of the time, they would also, if the trauma drama is selected as detracting more from the quality of life of stress-related disorder, usually this one would be checked too. That our fears, insecurities, or phobias, the primary thing you're seeking biofeedback to help you with. Only check this if that's the case. Bill's primary goals are not anxiety related. Do not check this box. Click. They are, we'll say. This item up here, for those of you in institutions, even intensive outpatient programs, you'll have to click this box here. And it says up here, no, this should automatically be checked for people under 18. When they are under 18, it will check it for you when you get to this screen. Those in inpatient or IOP, intensive outpatient programs. Yeah. So you just automatically pick that one. It's something that we saw our model was smarter when that was checked for those institutions, when it was seeing these clusters coming from certain places. That turned out to be what that was. Here's that item we talked about with benzodiazepines, where it reminds us whether or not it'll when it educates you and the client that 50% of them make just as much progress as anybody else, and the other 50% won't make any progress at all. It's reminding you of that. But the question is, is Bill currently taking any size dose of a benzodiazepine on a daily basis? Yes or no? Nope. So we leave it unchecked. Here are some items as well that have numbers in them for the frequency of it. These particular items, the software will create growth areas around them when we've left one blank. So here, if I say 30, it's how many nights per month does Bill have any of these? Unpleasant dreams, nightmares, night terrors. We'll just say 30 here, like that. Any questions on the evaluation tool? Yeah.
I have a question. CPTSD is not a codable diagnosis. However, I do see a lot of cases that it is listed in the literature with with PTSD in the DSM-5. And so I wonder, because of the overlapping traits of that disorder, which would you put that underneath trauma or drama, or the issues are more biological in nature because those do overlap so much?
Well, the answer is, and this is for all answers, whatever tools you use to try to differentiate issues won't be helpful with this. What it would be is what you just answer the questions like, do you think that the stress-related disorders detracting more from the quality of life, that it won't be related to any billing codes or things of that nature. It doesn't matter. But yeah, you just answer the questions as they're outlined, and no other extenuating circumstances will be remotely helpful to the tool. No other contexts are remotely helpful for the tool. So maybe you could give me an example of a client's issues that you think is borderline CPTSD or PTSD.
So I have a 11-year-old young lady who is in a very tumultuous type of family where there's drama all the time. There's yelling, cops are being called to the house. Stepdad was actually just removed this week for molestation charges, and this has been her life for the last 3 years.
Right.
So like it's definitely PTSD because it's constantly there, but anytime she does get a break, then she's going into almost CPTSD, getting ready for the next type of reaction that's going to happen at home.
Yeah.
So very complex type of thing. And it wasn't, I didn't mean to be not clear about the billing code, adding that into it. It was more of the overlap that there is no diagnosis for CPTSD. It's just in there because they're acknowledging that there are more complex types of disorders that do fall into this category. So with that, you ask the questions, I guess, and let mom answer the questions.
Exactly. Yeah. Do the primary issues that are now most detracting from her quality of life or performance, they seem to start after scary events? I would say yes, right? Unless she has brain damage, and yes, there's all these horrible things that happen. But boy, if I could only help her with the stress-related disorder, gigantic category of issues, or anything but that. That's really what we're looking at. If I could only help them with one of those two things, we can help them with both. We can help them with both usually. But what is detracting more from the quality of life? And here it would likely be that. So whether she's and when she's not currently being re-traumatized, she's anticipating it and has all the fears of it. All of that started after scary events and things of that nature. So that would definitely qualify. But like I said, just because she's having all these horrible things and has this horrible history as well wouldn't always make it. So if she also had psychotic features, for example, not necessarily dissociation, she likely does dissociate already. That's like a classic symptom of PTSD. But if she had psychotic features and or some major depression where she's always slow and sluggish and moves slow and talks slow and things of that nature, the software wouldn't likely give her alpha theta, even if you said, oh, because she has this, she needs alpha theta. The software would say, you're absolutely right. She does need it. We just need to teach her brain to speed up more first. And it will come up with a training strategy that would do that first. Then she would meet next week's topic. When do I do something different with everyone? The machine would say, hey, are you ready to, it looks like this, have you been documenting progress for this client? And when you say yes, then it will say, all right, they're ready for your cheat sheet to do the next step with them. And that's when it would start giving that person the stress-related disorder work, the alpha theta, always eyes closed at alpha theta. But yeah, that's that. Very good question. Yes, Nicole.
Hi, I have a question.
Yeah.
So I'm getting caught up in like having to pick between those two, like the issues of the trauma drama or the issues more biological in nature.
Yep.
But say there's like a client who has a history of childhood trauma where like things had to be a certain standard or else he'd get yelled at or get in trouble. So now that's showing up in his life currently where he has like imposter syndrome, perfectionism tendencies. Would that be an issues are primary trauma or drama related?
Yeah. What the trauma drama items are, they help exclusively with would be issues that started from the external world and now come up in reaction to the external world. Across the board, period. Every one of those. Every one of them. seem to start from events in the external world and now primarily come up in reaction to the external world. That is every stress-related disorder
Okay.
that there is. Yeah.
Okay. So even if that person's on antidepressants and they're finding it helpful, like that was in the description for the issues are more biologic, I'd still go to that issues are primarily trauma or drama
Well,
related.
that's another question. You could do that. You can click that, but then we also, when we get down here, if it, let's see, was helpful, was helpful. What I usually would get with people who found neurofeedback, what I would usually get when medications have been helpful, it's always, yeah, it's a little better when I'm on X, Y, and Z. And it's a long pause and they have to think about it a long time.
Oh, okay.
Often very questionable. How much better? Those are people who found neurofeedback, that is, because if when the medications are helpful, they might not need it so much. And so in those cases where the medications were, let's see, what does it say? Have you had a clear positive response from antidepressants? So we have to phrase it like the questions are. So we just said, have you had a positive response from them? That, when they're vague, that's not clear. If it doesn't just roll off their tongue like, yes, here's what happens when I'm not on it. What you usually get when people are on medications are like, yeah, it's a little better. It's hard to tell how much of an effect it's having. It is. There was a time it worked really well, maybe for the first 3 months I was on it, but now I'm not quite so sure, which is why I'm here.
Okay. So if it's just taking the edge off, then that isn't a significant positive effect.
Yes, it's not a clear, it's not a clear positive.
Clear positive response.
That would
Okay.
be a vague, that it's usually like a vague positive response. I wouldn't qualify that for it. Yep.
Okay. Thank you.
You're welcome. Welcome. All right. So now I'm going to do two things. I'm going to click the Get Protocol button. First, I'm going to try to make this look a little more human. And then I'm going to show, who was it who had the question? We missed the growth area. What was your name?
Sorry, just to clarify, we're not asking them these questions. This is our observation, right?
No, you have to, it'll be primarily your observations for things that you've observed already. Like if you saw impatience, for example, that would answer one of these questions. Excessive states of excessive urgency in which you're too demanding on yourself or others. Do you get into states? If you've seen that already in it, then you don't ask it. But no, they are two. Unless you've already seen the answers to them. Some of the questions, like this one, slower speech, less aroused affect. These are ones that they're telling you to not ask the client. They're just using your own observations.
Okay. And then for children, we're doing that with parents.
Yeah.
What do we do if a parent is not like a reliable source of that information?
You pray to God for intuition. I'm thanking you in advance of your service. I've been in that situation. It is uncomfortable. We do have a brain print procedure that we teach on training day 3. When you know something is more organic in nature, that's subtracting most of the quality of one's life, we could do this thing on their temporal lobes where we run this continuous performance test. They play this game. It sends me their brainwaves. Within 2 business days, I send you back a training protocol to begin. That is a godsend. We use that exclusively in our nonprofit clinic with over 2,000 kids over a 12-year period. And it knocked it out of the park with them because most of their parents were not English speaking. So we did that, and it was almost always for ADHD and things like that. But we do have that training approach. But yeah, another problem is, we'll get more into this next week too, when the parents drop the kids off and won't return any phone calls about growth areas or things are better. And the average adolescent, when they're 17 years old or under, the average response is, how many panic attacks have you had in the last week? I don't know. Or if the girlfriend didn't text him back 5 minutes before the session, everything's worse than ever. That's feedback. Worse. What do you do with that? So what I'll do is I often, where appropriate, you could, snap a picture of the growth areas, text it to a parent and ask them about it, or send a screenshot of these other responses since the last session that you could get from it, and just stay on them, because boy, it's tough. One other thing too that I do, if you have like people who are really obsessional, I would say just OCD period, not even excessive cases of it. There too, there's a symptom, and there's no other collateral contacts, no other therapist, no other mate you can check in with. There too, there's a symptom checklist 90 on the desktop of it. I'm sorry, when you open a client file, there's a program that's a symptom checklist. When you think someone's a terrible reporter, that test will nail it, even for people who don't want this to work for them because they're going to lose benefits from disability and things of that nature. It will reflect changes in them even that they either can't see or don't want to report. Yes, yeah. Any of those standardized measures I find do a beautiful job at identifying the effects of this work.
If we feel like the teenager that we're working with can answer the questions, can we ask them? We have a lot of kids in foster care. When they get in foster care, they don't really know the foster parent doesn't know them. If they're like not involved, we feel like they're pretty mature. Can we ask them the questions?
Yeah, if there's anybody who's observed them for more than a week or so, there's usually someone you can. We also have a model that we've done with some treatment centers where everybody starts out, they do 20 of the BrainPrint only protocols, and that will prepare everybody to do the alpha theta at some point down the road when they clearly plateaued with that. And then we give them then 20 protocols with alpha theta with the 10 minutes of the BrainPrint. That is amazing. We're doing that. We've been doing that for the last few months in the Ukraine because of language barriers as well. And that's knocking it out of the park. That's basically what we did in 2 clinical trials that BrainPaint is based upon, where they did an average of 13 beta and SMR only, eyes open only protocols. And then they did 30 alpha theta sessions. And it seems like it was overkill in 2 clinical trials with addicted populations who did that concurrently. But that's another thing that one can do. If you end up with a large population where no one knows anything about them, there's nobody who can refer to that, you can check in with about the growth areas. That's what you could do. And any other standardized measures that you have, you could use those to empirically track progress as well.
Thank you.
Welcome. So I'm going to check some other boxes here.
I'm going to tie one more question into what they were asking. Is there any way to do, because working with 25 kids, 20 of the parents will not ever contact me. So it's like this weird support parent system thing that I do in therapy. And I'm wondering if there would be a way to do 2 evaluations and then take the average of the 2. Because I know teenage girls that will not tell their mom or dad things because they're not safe, especially my cutters.
Exactly. Yes, exactly. What I would do there is, you likely have a sense of if a stress-related disorder is detracting more from the quality of their life than anything else. Than any other, bipolar symptoms you're beginning to see, or any major depressive symptoms, or any generalized anxiety issues, or anything. But when you're seeing that stress-related disorders are there, you could conduct the brain. There's a streamlined assessment, because you're saying 20 of 25 of them you're not going to get adequate information from, or it's not safe for them to report that information to them. There's a streamlined assessment I'd love to teach you to set your equipment up for, that will eliminate all of these questions here that you have, and you'll be arbitrarily picking one of 3 different options. Temporal lobe only BrainPrint, that's the same as doing these beta and SMR that this is going to come up with, or protocols with alpha theta and 10 minutes of the temporal lobe only BrainPrint. Or the third option you pick is the bipolar option, or the multiple chemical sensitivities option that will come up with the nonlinear protocol. That will cover your bases really, really well. The thing that it won't do is when we mistake someone as being if someone has all this under-aroused activity and they're sleepy and they're weepy and they talk slow and they're waking up, they have a million of these under-aroused symptoms, this assessment tool we're looking at here nails that perfectly, where that one won't. So there'll be some people who would fall through that crack, where if you're using next week, when do we do something different with every client, you're using that criteria where you're not seeing observable goals. Example is the number of scars on their arm from cutting, or the size of scabs or what have you. Very quantifiable goal. If you're not seeing that within 5 to 8 biweekly sessions, or 10 to 12 at once per week, then you'd know. Or if you were seeing some negative reactions, like less self-care happening, or they're having more of the depressive states when you're giving them alpha theta, you'd have to look for some of that. But that would be the best if 20 out of 25 people, you can't get any additional information from anyone. I definitely would use that approach. I would knock it out of the park. There'll be some exceptions to it where it won't work immediately right away, but that'll be by far the exception than the rule. And you'd have to change gears with them after that. Gotcha. So what you could do for that, Amanda, is you can set up an individual time with me to walk you through that. When you have the equipment, someone else to practice on, I can set your machine up to do that. What are your thoughts on that?
That would probably be the best way to do that, so that they're getting the care that they need. Because at times, the parents can't answer the questions, and the kiddos that come and see me, depending on the level of fight or flight that they're in, that's how they're going to answer the questions. So being able to have the system that would help them understand, well, they're not going to understand, but the system's going to understand, that would be a great resource.
Very good. Very good. All right. So now I'm going to click the Get Protocol button down here when we're done. Also, if ever you can't finish one of these, and because you ran out of time, which will happen with your OCD people as well. I don't need to bash OCD people, but that's one of the also reasons they can be challenging. You can click the Get Protocol button here, and then when you open the client file, I'm going to show you this. Then I'm going to show you the screen of inputting the growth areas as well for the individual who couldn't see that. So here's my client file. All subsequent, I hit the Start Session button. Now, so here's what I did. So now to run a session, after we did the evaluation, again, we never click the new evaluation ever for an existing client. Please, the computer will lose a lot of its smarts. So to run a session, we hit the Start Session button. For this client, whenever we want to, from now on with this client, we just hit the Start Session button when they're ready to start a session. That brings up our client list like this. Here it says double left click to open client files. So we double left click just like that, and it opens it up. Here's the re-evaluation button. It's going to be all about next week when we use this, but one could use it if you couldn't finish the evaluation. Here's a growth area created also about nightmares from the assessment tool. Okay, so I'm going to show you the individual who didn't see the growth areas. I click the new evaluation. Now this is just for that person who missed the entering the growth areas. Everybody else, you can take a 10-minute break, come back. If you haven't plugged your BrainPaint laptops into a power source, plug them in and turn them on, and I'll walk you through connecting everything else. But get your person you're going to be practicing on when you come back from this break, and we'll come back at the top of the hour with your person to practice on. But you who missed the growth area input, can you see who was that? Who missed that?
It was me.
Okay.
Yes.
No worries. You can see it now, I take it, Alexandria?
Yes.
All right. So we put in maybe a first name, a
Yep.
last initial, maybe a date time stamp, something like that, an age. And then here are the growth areas where we would input them. Did you get the training slides in the chat feature too?
Yes.
There's one in there in the training day 1 section that you'll see the AI prompt for it. That's where it can help you, that prompt, when you put that in any. Do you ever use AI models yet?
Yeah, I do.
Cool. Me too. They're amazing. Well, that prompt that I gave you will help you make growth areas pretty good ones. You'll just have to tailor them a bit to your client's needs. But they'll always be coming up with something you would see on a video camera without words is what makes the best growth areas. That like the number of times someone feels depressed, the number of times they feel anxious, or how often they obsess isn't that quantifiable. But when they're obsessing, the software will say, but are they late to things because they're obsessing? Oh, yes. How many times does that happen? But we also have here, Alexandria, the button above the growth areas that we can pick for different categories. Like, do you have a particular client in mind that you're thinking about doing this with?
Let's see here. Yeah, there's lots of them. The guy that's actually here to be my guinea pig, he's had multiple concussions
Uh-huh.
over the course of his life. He's in his mid 60s.
Uh-huh.
I also do believe that he loses his train of thought multiple times a week.
Yeah.
So that's
Okay.
where
So one thing we could do with that, we could look at it from the perspective of attention, maybe, where I miss so much in lectures, I can't recall, or 2 times a day I miss things someone said to me and I have to ask them over again because my mind wanders. That would likely be a pre-made growth area. And then you can change the numbers whenever we see a growth area. We can always edit the numbers of what they are. But notice that it has this colon after it. If you don't put this colon in after it, the machine will bother you to categorize it. When you opened it up, it would say, hey, you don't have a category. What category best fits? Or is it an other that it would ask you about it? And then when we hit the next button, that's when it would get to that screen with all the questions. But we want to create at least 3 of these growth areas per. And if you had somebody like, has PTSD and other issues, like that individual probably also has some PTSD. They're a great starting candidate, by the way, as well. All these issues that they've had for years, many of those tend to come back that they lost from the TBI. In addition to just the cognition, like a sense of smell or certain visual things or certain movements or any language, speech impediments even that they had tend to improve pretty observably. Yeah.
How does this work with, because I have you for you probably want a break, so I'll wait with my question. I have a question.
No, go ahead.
Well, I'm working with a speech pathologist at Missouri State University here in Springfield, Missouri, and she's a swallowing specialist. And her and I had a meeting the other night, and I was like, man, I wonder how that could do. But she's also involved in the Parkinson's networking group here in Springfield, Missouri as well. And
awesome. Go on.
So she heard about what I was doing, and she's like, hey, I want to get published with you. And I'm like, okay, we can do that. But I'm like, shoot, this is a whole new arena for me. But the Parkinson's thing is a massive deal. And I was reading in some of the abstracts that I have about the effects of Parkinson's and neurofeedback. What has been your experience with Parkinson's and neurofeedback?
It's remarkable. I can't recall hearing of a single case who didn't have remarkable, fast, observable effects within 10 sessions. Not that they were done after 10 sessions, but many abilities they had lost. And a lot of them also were in the very progressed phases of it where they could barely talk anymore, where their voice gets real quiet. Yeah. Like they can't project, and the shaking is the first thing that we see going away when that's visible, and then even the internal shaking that they have. Movements, the mood disorders that tend to accompany that improve pretty quickly. Like one really quantifiable test, it's not you're given that your partner probably specializes and they're called movement disorders. They probably have some very standardized testing that they do. I would love to help you publish an outcome study where you have visual evidence of the individuals and or if they had like a more treatment as usual, like if there's so many people that they can't do this with everyone, you'd have one group randomly picked to do another group randomly picked to do another, and then you do a blind rater exam. You have people who don't know who did what. Identify who's making better progress with this standardized testing that they're doing. That would put this on the map with that. It would likely also make insurance have to pay for it for that issue. One thing about it, we can't reverse the progressive neurologic deficits like Parkinson's is, but the quality of life that we give them is tremendous. And yeah, I suspect it's lengthening their lives as well. But how could you tell that? That's not so easy, because what we typically see, people have been suffering for it severely for like 4 or more years. We'll usually see them regain being able to do things within weeks that they couldn't do for like 2 to 4 years. Yeah.
Right.
Yeah.
Do you have that? You probably have that literature? Is there any way to share that with me? Because I'm meeting with her on Sunday to drop off my abstract book. And then what she does is she's been published multiple times this year. She's been doing this for years. And she's like, let me find the gap in the research. And I'm going to get a pilot study together. And we're going to go after pilot, and then we'll go after a grant.
I love it. I love it. Love it. Yes, here comes some clinical trials right now. I think I probably have all of them, but more will be revealed. There's only a couple with humans and a few with monkeys or animals, which I wasn't involved in any animal studies, but they're quite informative. Hold on.
No, you're good. Take your time.
Here we go. Parkinson's. Okay, I have 4 of them. Here we go.
Woohoo! Download. Let's go.
Yeah.
And that opportunity just kind of fell into my lap. I'm involved in a holistic networking group that involves doctors all the way down to acupuncturists. And I say down, not in a degrading way, but like all the way across the scale of folks. And I was asked to be their primary mental health person in the group. And Dr. Bonnie is the speech pathologist that's there. And it was her spotlight evening, and she started talking about all the Parkinson's group she was in. And then I remembered the abstracts that I had read about Parkinson's and this equipment, and I'm going, holy cow, like this could be a total game changer here in Springfield, Missouri, more or less everywhere, if we could get published, because insurance would have to pay for it, because it does change quality of life.
Exactly. Yeah, very cool. I have to return a phone call here in the next 4. See you in a bit.
All right, talk to you soon.
Yeah.
Hey, you're still sharing your screen, just so you know.
All right, everyone. And thank you, everybody who have come to donate your brains to science to practice placing sensors. So, if you haven't already done so, on the screen that said Get Protocols, go ahead and click your Get Protocol button to finish that. But we'll do later, before you do any sessions on yourselves, make sure that we all do a thorough evaluation on ourselves as well. You don't want to just try to get to the feedback quickly, or you'll have some odd reactions to it. So for the remainder of the day, what we'll be doing is just looking at my screen as I'm showing you a particular placement of the sensor. And at the very end of the day at 4:30 Pacific time, wait, no, not 4:30, 2:30 Pacific time, I'll be showing you how to conduct the two types of training that happen. So what we can do next here is I just hit my start session button, and I am going to just click save note and start feedback. We'll get more to all of this next week because this is only relevant for documenting progress. What we do with all these sliders and how do we document progress with the growth is only relevant for next week. I left something checked in mine that made it come up with a nonlinear protocol. All right. So now here's where the rubber meets the road on the one thing nobody can get from having another clinician teach you how to do this very effectively at all. But I know exactly how to teach you all how to do this. So I'm just going to get to my head screen here where it comes to showing us how to place a sensor. So I'm just hitting the save notes and start feedback. And I'm first going to click on a protocol that has the words alpha theta in it. So I'm clicking on that. And here's a message. Here's a thing with BrainPaint. We have a 120-page manual that I will put in the chat feature before we're done today. However, if you just slow down, take 20 seconds, and read these little pop-ups that come up, you will not have to memorize a 120-page manual. Yeah, that's critical to the process, as you can imagine, that we stop and read these. I cannot replicate my own results without reading my own messages. I wrote the software. I can't do it. I can't replicate a practice. I just click no or yes or whatever. When things come up, it's not going to work. So we just have to take the 20 seconds to read these things like this, where it's saying Bill's assessment suggests using this distraction exercise in the first 3 sessions will make his training significantly more effective and enjoyable. We recommend Bill just receive 7 minutes of alpha theta training and not receive any eyes open feedback until his next session. Want me to change his minutes and guide you through this methodology? Sure. Don't know what it is yet. You don't have to. The machine will do it the first for you. So I'll just say yes to this. Okay. And now, because we didn't read it, you'd think your machine was broke. And you say, hey, it didn't give me all my protocols. It only is giving me 7 minutes. You'd think it was broken if you didn't read these, but it'll tell you everything that it's going to do and usually why it's doing it. In the first session, we reduced the minutes to 7 and we'll conduct the distraction exercise for you. Okay, great. So I'm clicking OK to this. Now, this is what we call the head screen. So everybody's just going to be looking at my screen for the rest of the day as I walk you through what does this mean? It might look a little Greek to you right now, but I will do that. But I'm going to click on my sensor help button down here, which will give us some things that I'll show you. I'm going to, these are infographics that we'll bring up where it says help placing sensors. So I'm clicking on that. So let's do this next. Initially, I told you, let's just plug it into the amplifier. This is the brainwave amplifier, this little box here. So let's take this out. There's a USB cable, just like a printer cable like that. This kind of smaller round end goes into the isolated USB port like that. Then there's another end that looks like this. There's a little trident symbol on both of these that you can see at the top. That goes into the laptop. And it will make a sound and lights will come on. We don't care what the lights do yet because we don't have them on anybody's head. The next thing we'll want you to do is this is your sensor cable like this. If you look closely at it, you'll see there's a little arrow at the top of it, like that. That little arrow has to be up, and we just insert it into the amplifier like that. And now our sensor cable is plugged in. Here's a tip. These cables would cost you $100 when they break. And if you put it in a laptop bag like this, every 5 times you put it in a laptop bag, you'll be breaking these cables. So always unplug everything from everything before you put it in a laptop bag. Unplug everything from the computer as well, or it will break the laptop also. The motherboard will crack if you leave it in. The power cord, so unplug everything from everything when you transport it. It only takes 30 seconds to plug all that stuff in, and that will...
Sorry, did all this. I'm trying to finish my Walmart order before I forget for Shabbat. I've learned how to multitask like really well because I have single mom issues over here.
So then we plug this in with a little arrow up like that. All right, so that's how we plug the equipment in. One thing about transporting the equipment, you can leave the sensors plugged into this flat gray cable. These don't break anything when they're left plugged in like that. I'm just going to make mine, take mine out here and take these. So we have all those plugged in. And here's the sensor. So we have a black sensor in the G hole. Some of you may have a white sensor, which is your ground in the G hole. Most of you who got your new equipment, though, I mean, everyone who has new equipment will have a black sensor, and there'll be a blue sensor in this R1 hole, and this green sensor in the A1 hole. That's what we want for these.
So I've got yellow on the left, white in the middle, and black on the right.
Oh, what group are you with, Christina? Gulf Breeze Recovery?
Yeah.
Oh, yeah, they've gone rogue and they buy their own sensors from I don't know where. But yes, what we want though, do you have ear clip sensors, Christina? Like these?
Do I have what? I'm sorry.
These are ear clip sensors. Are they like little clothespin sensors?
Yeah. So I don't in the video that I watched before the class, it said that you're supposed to get like a box, but I don't have a box. I'm just using like our actual station that the clients use.
Yeah. Yeah, that would be like the equipment would arrive in a box. Yeah, your equipment's been there for, I think, about 12 to 15 years. Gulf Breeze has been using BrainPaint now. They take it very seriously. I'm really proud of them. And so, do you have an ear clip type thing, Christina? That looks like you could clip it to somebody's ear.
I think this is it, right?
Yeah, yeah, it's like a clothespin like thing. Yep, got it. So, that will have to go. One of the ear clip will have to go in your R1 hole. Then you have I saw also in your setup there, you also had a green sensor that's a scalp sensor. So there's ear clips that are like this that you could clip to an ear. And there's scalp sensors. There's only two types of sensors we have. And so we want if you have a scalp, we want a scalp sensor in the A1 hole. It would typically have come that way with your new equipment. And we also want an additional ear clip in the G hole of your flat gray cable. If you look closely at this flat gray cable, you'll see A1, R1, and G. And that G sensor will never have to be removed from that. It will always be in that hole. Similarly, the scalp sensor will always be in the A1 hole. But there'll be times, which I'll show you, when we have to unplug the blue scalp sensor in an ear clip from the R1 hole. So right now, everybody has a blue scalp sensor in your A1 hole. I'm sorry, a green scalp sensor in your A1 hole, a ear clip in your R1 hole, and an ear clip in the G hole. It's anyone who does not have that yet.
Question.
Yeah.
So on our BrainPaint computers, should we have already gone through and added the growth areas and done the questions already?
No, we're going to be just following along on my screen for that for the rest of the day, because everybody would have random protocols otherwise. And I have a very consistent protocol that I want to show you. So I'll just be showing you on my own head screen here, which I brought up. We're only going to be going by my head screen here. I clicked my sensor help button. That's bringing up these infographics that break this down in one step at a time of placing sensors. That's what we've done here. Yeah, so everybody else, for the rest of the day, we do need your laptop turned on and plugged into a power source. We never want them turned on without being plugged into a power source, so they actually break, oddly enough. And yeah, so, all right, so we all have that. We have a scalp sensor in the A1 hole. Does anybody know what I mean? Does everybody not know what I mean by a scalp sensor or an ear clip? There's only two types of sensors we ever have. This is a scalp sensor, nothing that it could clip to an ear with. And we have ear clip sensors like this that will clip like a clothespin clip. Yeah, and so we have okay. Now, I'm going to click next here. This may seem trivial, but it's not. You want to slide this little clip up so that it's near the end of this flat gray cable, and then clip this to your person's shirt. Otherwise, when they move, the cable falls off their lap and it keeps pulling the sensors off their head over and over again. So go ahead and do that next. And Christina, you don't have anyone else to practice on? Are you going to be putting these on yourself?
Yeah, yes, there was somebody else who was supposed to do the training with me, but I think that they were off today.
Oh, I see. One thing with that, it's about 4 times more difficult putting them on yourself than another person. So that could be discouraging without it. Yeah.
I'll see if there's somebody.
That would be awesome if you could find someone, because it's a lot more challenging. It's something we really try to emphasize the need for that, having someone. Okay. So that's the gray cable. Now, this is letting us know that even though there are ear clips that could hold the sensors on in place, they always require paste on ear clips. But before we do that, we always have to thoroughly scrub. We can't wipe the ears. We have to thoroughly scrub the earlobes until they're pink. Which I'll show you in the next screen. But before we put the ear clips on, we have to put a nice generous dollop of paste on the ear sensors. Also, you never want to use the tubs of paste. There are tubs that you'd have to unscrew a big jar-like lid. Only use tubes of paste. The reason is the jars, when they get half full, the top layer dries out, and you can, no matter how good you are, you'll think your equipment's broken. That can't happen with the tubes of paste, that you have to squeeze it out like a toothpaste tube. And so this is letting us know also, never use alcohol swabs, only use paper towels. Paper towels are perfectly abrasive, and they rub off an oil, a layer of dead skin, and the alcohol dissolves all the oil in us. Okay, and now here's an image of us thoroughly scrubbing, and these images also are anatomically correct. So how we do this is you have to pinch, soak the alcohol soaked paper towel, and pinch the entire earlobe and then drag it hard enough so that the earlobe is stretching. When you do it like that, and also we want to clean the entire surface of the earlobe. If somebody has earrings in their ears, they have really big earlobes, you could leave them in, just making certain that the ear sensor will not be touching the metal of an earring, or that will not work. But if they just have little tiny earrings and they have, you'd have a small earlobe, you'd have to take that out then. So also, when people have gauges in their ears, we can thoroughly scrub the upper cartilage of someone's earlobe up here. But when we put it on up there, we have to kind of pinch it closed, because otherwise it won't close properly on it. So you put it on, if you had to put it on the upper cartilage of their ear, that will work well too. But what I'm really wanting to drive home here is we have to thoroughly scrub every surface that we're putting a sensor on the ears, and eventually the scalp, which we'll get to. So it's thoroughly scrub hard enough, the entire surface of the earlobe. If we clean just one little spot, we'll never find the spot we scrubbed. And when we develop that as a habit, you can rest with 100% certainty that the ears are never the problem when it comes to trouble getting our lights to flash yellow or flash green. And what I typically do for this, if I don't have an applicator stick, I'll just use my finger, which I'll smear some paste out, and I put a nice half of a pea size of paste on both sides of my ear clip, like that. Nice, generous dollop of paste. If we're trying to be, I don't want to mess up my colleague's hair or their ears with this messy paste, they will usually be feeling that way too. And go, why are you messing up my hair? It's when we're feeling sympathetic. That is, we want to be empathetic, not sympathetic. The autistic kids would be screaming and running out the door as soon as if you're feeling like, I hope this doesn't hurt your ears. I know you scream when your ear touches your collar of a shirt. If we're feeling that, the kid's screaming before we even get near them with a sensor. When we hold a larger picture view that this is about the tens of thousands of hours in their life, we get this amazing compliance. But if it's all about, are you going to be able to tolerate this or not, then that's what people are going to be feeling and thinking. Am I going to be able to tolerate this or not? That's going to be their reality. We make other people's reality, our reality, other people's reality. We're quite reciprocal that way. All right, so we thoroughly scrub, in this case, the left ear. I'll just foreshadow, go ahead and thoroughly scrub your person's right earlobe as well, because we will be, both the front and back side. But pinching it with the soaked paper towel and alcohol, dragging down hard enough so that the earlobe is stretching like that. That is enough pressure. If it's not, it isn't. And yeah, okay, so we got both earlobes are scrubbed. Now we put a nice generous dollop of paste. We already did that. And this will be our blue ear clip for most of you who have the sensors that we recommend using. Will go on their left ear. Put a nice generous dollop of paste on it.
Is it on both sides, Bill? This is the first time I'm using these clips. I'm having her train with the new ones. It's both sides.
Yeah, the blue ear clip will go on the left earlobe. Yep. And will be going on the right earlobe.
But the paste goes on both of them?
I
Okay,
understand. Yes, exactly. Yes, both.
got it. Thank
Yeah.
you.
Welcome. All right. So then we put the blue ear clip on. That would be the left ear. And then the black ear clip, which is in the G hole of the flat gray cable, that goes on the right earlobe. Amanda, I see your hair is in a bun. Hi. Yeah, you might for the next one. This is the alpha theta protocol that we'll be doing. Yeah, if somebody's hair is in a bun, it would seem like it would make it easier, but it actually makes it harder to get connections because when the hair is pulled back tight, it's harder to kind of part the hair to see the scalp and not. So it looks like now everybody's caught up with the ear clips. Oh, we have one more person. I think Fernwood's still putting on ear clips, I think, right? Fernwood. Nice. Gosh, you guys have an AV person zooming in? You are awesome. I don't think I've ever had that before. Oh, okay. I see. Got it.
We stole our psychiatrist robot.
Oh,
Great.
nice.
So
Awesome.
it's high tech.
Beautiful, beautiful. Okay, so now to find the spot on the back of the head, I'm going to show you how we do that. Ordinarily, we're not doing this in conference rooms. You'd have a recliner that people would be sitting back in because this is an alpha theta session. And to find the spot on the back of their head, you'd have them first lean their head back. If there was a chair, but we don't have chairs with headrests right now. Nobody ever does in the trainings. But imagine if your hand was the back of a chair. One hand was the back of a chair. Where we want to place the sensor, when you do have a chair, this is what I do. In this picture, I have them lean their head back first. Oh, most importantly, get the paste on the scalp sensor first. Nice, generous half of a pea size of paste on the scalp sensor first. And then, otherwise, what happens? This might seem trivial. Otherwise, you'd scrub the spot on the head, and you'd put the paste on the sensor, and you'll never find the spot you scrubbed. And you'll be in a loop that way. So if you get the paste on the sensor first, and I hold the sensors in a very specific way, most of you are likely right-handed, so you would be maybe parting the hair with your left finger. But here's how I hold the already pasted sensor. So where do we find the spot? First, you have them lean their head back where it would not be able to touch on the back of the chair. In the back middle, above that spot, toward the ceiling, we find the spot, and then we have them move their head forward like that. So now her head is forward where I can reach the spot. So where that spot would tend to be, if you had an angle iron, they're called, or one board on the top of their head and a board on the back of their head, there'd be this little gap that would create where the two boards met. There'd be like a gap. And that's where we want it, so that when they lean their head back against the chair again, the sensor will be just above this spot, about an inch where it cannot touch on the back of the chair. Otherwise, every time they breathe, the signal goes all over the place. It'll brush the sensor off their head over and over again. They'll get paste on your chair, all this other stuff. But the back middle of their head, just above the spot where it could not touch on the back. Oh, and look at what I'm doing in this picture. I have the paste on the sensor. So here's how I hold the sensor. Again, this might seem trivial, but it'll be very helpful. Just I have my left thumb and my left middle finger that I'm going to use to part the hair, and I have the already pasted sensor ready, so that when I scrub on the head, once I part the hair and I can see a nice clear spot on the scalp, I can scrub it hard enough to where the head is moving. That's enough pressure. If we're being too gentle, their head won't be moving. But you just scrub back and forth hard enough where their head's moving a little bit. And then when you see that it's turned pink, without losing the spot, you really quickly just stick the sensor down on that pink spot, and you'll get a good connection nearly every time. I'll give you one more tip after that, and what we can do when someone doesn't have the lights flashing yellow or flashing green here.
And can you repeat what the lights are supposed to look like when we know it's been set up well?
In any sequence or any combination, the key words are flashing. Flashing yellow or flashing green. In this case, we only have sensors in your A1, R1, and G hole. So we're only concerned with the top two lights, flashing yellow or flashing green. Some amplifiers, a bad connection would be flashing a dark red.
I've got a green flash on my R1 and then everything else is like solidly greenish yellow.
Well, we shouldn't be concerned until we get all the sensors on one's head first. And if you jumped ahead, you'd likely missed a few spots. Yeah, so we can't tell what the lights are going to do until we get them all on one's head. Yeah. Was that you, Christina, who had that question?
Yes, so we should have the two on the ear and then the one on the back of the head, correct?
Correct. Yes, yes. I'm good. We're not done yet, though. But currently, yeah, we're not completely done yet. All right. And the one thing with you, Christine, you got ahead of it. Also, you're doing it on yourself where you can't really see the spot you had scrubbed real well. So now you have all three sensors. You have two ear clips on your ear. The blue is on your left ear. The black is on your right ear. And you already stuck the scalp sensor on your scalp. Had you already thoroughly scrubbed the spot on your scalp first, do you think? Oh, unmute yourself, Christina.
I think so.
Okay, yeah, that's the thing. You won't be able to really see it on yourself to see what you're doing on the back of your head usually. That's why having somebody else to do this with is critical. You know what, Christina? Let's have you just only for the sake of our training. You can't do alpha theta sessions on your forehead. Why don't we have you thoroughly scrub a big spot this big on your forehead? Where you can stick a sensor, because that you'll be able to see and you'll get a sense of how hard you actually have to scrub, where you literally will need to scrub hard enough so that your head moves a little bit. Again, we can never run alpha theta sessions like that. But all right, so now among all of you who had someone else to put sensors on, how many of you, is there anyone here who does not have your top two lights flashing yellow or flashing green yet? Who does not have your top two lights flashing yellow or flashing green? I'm going to give you one secret tip that's going to solve this about 80% of the time. If you don't,
do they have to be flashing the same color, or can one be flashing yellow and one be green?
Yep, one can be flashing yellow, one can be flashing green, one could be flashing green and the other's flashing faster green. But flashing yellow or flashing green in any sequence or combination is an equally acceptable connection. The bottom two lights, we don't have anything in those A2 or R2 holes or a flat gray cable. We only have three sensors on the head, so we're only concerned with the top two lights. But if one was staying solid yellow for several seconds, and the other was, if one of the top two lights were staying solid yellow for several seconds or more, that would not be an adequate. Or on some amplifiers, if the lights were flashing red, when you're looking down on it, if you hold an amplifier and you look at it like this, they'll always look red. But when you're looking down at the amplifier, flashing yellow or flashing green in any sequence or combination are all equally acceptable. Wes, did you already get it to flash yellow or flash green? Whoa, way to go. Oh, and you're in an actual neurofeedback chair. I don't recall that ever being the case before, where you had her lean her head back and found it. Is there anybody who couldn't get your lights to flash yellow or flash green yet? Because don't try other things yet. I have a tip that I'll give you that'll solve it nearly every time. Does anybody have any trouble getting your top two lights to flash yellow or flash green?
Mine aren't flashing correctly.
Okay, so before we do anything else, just a thumbnail size. Tear off just a thumbnail size piece of your paper towel. And yeah, only a thumbnail size. And what we're going to have you do is just pack it down firmly with some opposing pressure. So put one hand on your forehead and the other on the back, and press down firmly and leave that little thumbnail sized piece of tissue on the back of the sensor. So when you pull your finger away, it's not going to stick to your sensor, to your finger, and pull it back off their head again. And yeah, just a thumbnail sized piece of tissue. The sensor's on.
Still
Yeah.
blinking.
What's going on there, Nicole?
Still blinking.
Oh, it is blinking now.
No, like the red and yellow.
red and yellow. The red, when one of your lights are flashing red, you said?
Yeah, like it's like it's doing two top ones, red and yellow, and then like green and red on the bottom.
Oh, you don't care about the bottom two lights. Notice in your flat gray cable how you don't have sensors in the A2 or R2 holes? So we don't care about those lights. They will do random things in the bottom. But your top two
are red and yellow, yeah.
Oh, red. One is flashing red and the other is flashing yellow?
It would be
what?
because it's the
It's really rare. We only have about 200 of those amplifiers deployed that the lights can flash red in.
I feel like it might be the back spot on her head because she just has a lot of hair, so her scalp's pretty
Well,
full.
see how she has her hair kind of in a bun or kind of pulled aside like that? That actually makes it more challenging to find the connection. Yeah, let that go. Yeah, like that. Because now you can part it. Because otherwise, when she moves her hair, she's sliding the sensor around a bit. So, and also it looks like it's way far back on the, oh, wait a second. Where is it on the back of her head there, Nicole? Okay. All right, yeah. So, Nicole, go ahead, take that sensor off for a moment, and let's do this. Let's get a nice, generous dollop of paste on it. If we were being, oh, I don't want to mess up my colleague's hair, you'll be just buttering a piece on. Get a nice, generous dollop of paste on the sensor first, and then we're going to have you pinch that scalp sensor in your index finger. Are you right-handed, Nicole?
Left-handed.
Left-handed. Okay, so would it be most natural for you to use your left hand to be scrubbing and your right hand to be parting the hair?
Oh, we're gonna scrub again, yeah?
Yeah, because you probably didn't scrub the spot first. Did you have before when you put it on, did you have did you already have the paste on the sensor before you started scrubbing, or did I see you put the paste on the sensor after you scrubbed?
I did it after I scrubbed.
Yeah, that is our number one cause of people not getting adequate connections with this, other than alcohol salts. So get the paste on you have the paste on the sensor first, and then you can pinch the sensor in a way. See the picture on my head screen here, Nicole, on the BrainPaint training screen on my screen. Notice how I'm using an index finger to hold the already pasted sensor while I use my other hand to part the hair. And then I can scrub on that spot, a nice clear spot on the scalp, so that when it turns pink for like 2 seconds, I can take that scalp sensor and stick it down on the pink spot.
Okay, I see.
Yeah. Yeah.
Sorry, Kara.
Excellent technique. And I can see your head's moving a little bit too, which is enough pressure.
It's pink.
Awesome.
Pink.
Yeah, you got this.
Ah.
Yeah. And then one other tip for everybody else is just develop the habit of tearing off just a thumbnail sized piece of the paper and always just pack it down over the back of the sensor. That will push the paste into the sensor. When you pull your finger away, it's not going to stick on your finger and keep pulling it off of their scalp. And then two, during a session, if one of the lights stops flashing yellow or flashing green, or one of the top two, again, we don't care about the bottom two, you can just pack that down firmly. Say, hey, client, can I press that sensor down? Looks like we lost our connection. And you just press that down, let it go, and you're good to go.
Oh, there it is. What's going there? Kind of.
Oh, one other thing too about placing sensors like this also, when we're moving the sensor on someone's head, the lights won't reflect the adequate connection until we stop touching their head for about 10 to 15 seconds. So now, Nicole, are the top two lights either flashing yellow or flashing green?
Still flashing red or yellow.
Okay, red or yellow. Nicole, what is the number? There's a 5-digit number on the bottom of the amplifier. It says SN. It's a serial number. It's 5 digits. What is that number? Because we have so few of those amplifiers. I'm wondering if you're misperceiving the colors or something.
41717.
41717. Yeah, that one could be flashing.
And then the person that I'm practicing on, she's also neurofeedback trained as well.
Got it. Yeah. Oh, and what is your name? The person who's getting the sensors on? What is your name?
Tara.
Tara. Yeah, and you've been running sessions for a long time, or you new? Okay. And with this amplifier, I take it that they do flash red.
Yes.
Okay, that we're not mistaking the. Okay. And what I'm wondering is how old might your sensors be?
Mm, I'm not sure how old they are. Let me message because Kim, she does it also, and she does it more than I do.
Okay, let's not worry about that because one thing is, and we do have your gray cable, the sensor cable is plugged into the amplifier now too, correct?
Yes.
Okay, very good. Yeah, don't worry about the age of the sensors. What is the name of your practice, Nicole and company, Tara?
Beyond
Oh, go ahead.
Beyond Therapy.
Yeah, I think you all are pretty new. I think your equipment, yeah, isn't more than a couple months old, so your sensors shouldn't be bad at this point. All right, here's what we know for you all. What we just covered, it really can't be the scalp sensor anymore. I think we might have been too gentle as you were scrubbing your person's left ear with the blue sensor, the blue ear clip goes. So why don't we take that off and more thoroughly scrub just the earlobe, that is. Yeah, don't mess with her hair too much or you're going to pull that scalp sensor off, I would guess.
Oh.
Yeah. Just scrub her left earlobe. Yeah. Yeah, if you kind of, when someone's moving hair around and stuff like that, it will kind of pull the sensors around and stuff too. It's a habit a lot of people have to put their hands through their hair as well. They'll knock sensors off. It's all right. Then we have to just put them back on again when that happens. But yeah, we are scrubbing hard enough to where her earlobe. Because if you're wiping, if anyone is wiping the ear like this, that can't work ever. So you have to thoroughly pinch it with the alcohol soap paper towel and drag it. And you're not using alcohol swabs either, are you, Nicole?
No, no alcohol swabs. Paper
Awesome. Yay, yay. All right. So now we thoroughly scrubbed that earlobe and we have paste on both sides, the little paddles that are going on.
Oh, not both sides.
Oh, okay, yeah, that will definitely help. Yeah, that reduces your chance of getting a connection by 50% when they're in just one ear. But the technique we covered and I observed, I'm like 90% sure that it could not be the scalp sensor. Must be the ear. Another thing too about the lights, it's good for everyone to know, is that if your A1 light was not flashing yellow or it was flashing red, it doesn't mean that that's the bad connection. It's always some combination between the R1 sensor and the active sensor, the scalp sensor. There's always some combination. That would be awesome if there was a way to test impedances with each sensor, but there isn't. All right.
We'll get him next time.
Okay, well, hold on a second. Now, did you pinch? Is her hair in a bun somehow or something?
There's a little bun.
Yeah, we don't want buns in people's hair when we're doing this. Otherwise, it's more it makes it a lot more vulnerable to kind of slide all the hair structure around. What you should be able to do, if your sensors are good, is you should be able to just pack down that scalp sensor now more firmly than you did before with that little piece of paper that you left on the back of it. Just pack that down nice and firmly and let it go for about 20 seconds.
Oh. Yellow and green.
But flashing, yellow or flashing?
Yeah,
that is equally acceptable. It takes about 15 to 20 seconds for the amplifier to catch up with what we did. Okay. Was there anybody else who had trouble getting your lights to flash yellow or flash green with this particular placement? Okay. All right. So that's one thing with the just foreshadowing 3 weeks ahead. If you didn't, there's a question in the oral exam of what is the most critical thing that you do before you hit the start protocol button? That if you don't know to check that your top two lights are flashing yellow or flashing green, You would fail the oral exam with that. We can't replicate our results without knowing that piece of it. But right now, if we were going to run this session, which we're not, we would hit the start protocol button after our top two lights were flashing yellow or flashing green, and the machine would run the session. We're going to cover that at the end of the day. But for the sake of our person's time here, who've allowed us to hook them up, we're going to, I'm just going to show you how to run some other protocols here that we will see. Let's see. What I'm doing here is nothing you would ever need to do. I'm just making sure that we have a particular training protocol. All right. All right, so now let's swap people. When you have multiple people who are getting trained today, let's make sure everybody else who's going to be placing sensors is going to, there's 3 different protocols that I'm going to teach you all how to place sensors. And so I'd like everybody to get some practice with this, because we're beginning to develop some muscle memory. That's really critical in this practice phase. And then if you practice a session after this, it'll really get ingrained in your brain's neural networks. Not give them adult session. So I'm just jumping ahead as though we would ran a protocol. And here's another protocol that we're going to run. So now the sensor, there's happen to be on the same ears. The ear sensors, if it was the same person you were hooking up, the sensors would remain on the same ears. But the scalp sensor's in a different place. Before, this is like the nose here, and that was the back of it. Before, we had the sensor back here. So now we can see, oh, where's that green sensor going? Oh, that's going on the left side of their head. And we can see by the left here. And so when the sensors are on the sides of the head, they'll always be 4 fingers above that spot when they're on the sides of the head. And how we find it is simply by, we get the paste on the sensor first, nice generous dollop of it, half of a pea size on the sensor first, and then you go 4 fingers above that spot. Which I will get to the infographics here. We did all of this already. Then hit that. These happen to be on the same place. And this is how we find the spot on the sides of the head. And we can be off up, down, left, or right by an inch. Won't make any significant difference. But we just go 4 fingers above the spot with the paste on the sensor first, is the most critical part of that. And then, and this is the left ear as well. This is anatomically correct. It would make a big difference if we put the sensor on the wrong side of someone's head. In terms of results, most people would feel a little more irritable and anxious after we did that. And then, just like we did before, we get with the already pasted sensor on, we're parting the hair, and I'm holding the sensor with a big gob of paste in it in my index finger, so I don't lose the spot that I scrub once it turns pink. And we scrub hard enough where the head's moving a little bit. Again, that might seem trivial, but it's a good kind of gauge and when you're scrubbing hard enough or not. Christina, are your lights flashing yellow or flashing green?
Yeah, the top 2 are flashing green.
Yeah. We don't care about the bottom 2 because we don't have sensors in the A2 or R2 holes and on our scalp as well. So good for you. Yeah, cool. If ever anyone is wondering if your sensors are broken, don't try figuring that out yourself. Just run the tech support icon or call the sticker on the laptop and let us help you figure that out. That can be challenging for you to find that out. You don't have to be an electronic engineer to use BrainPaint. We have people available between 9 and 5 Pacific time business hours to help you identify what it is. That is one thing that we would need you present to test the sensors with us to find out, or if the gray cable goes bad, these eventually will wear out as well. And we can help you do that all the time. A lot of times IT people will think they need to learn that, but no, just let us help you with that. Yeah. So 4 fingers above the top of the left ear. And once it turns pink, we stick it down. We tear off just a thumbnail-sized piece of tissue. It's a very good habit to get into, particularly with the next placement that we'll be putting these in. And only a thumbnail size. If you put a big sheet of it, then there'll be weight of it that could be pulling on that scalp sensor. Yeah. 4 fingers above the spot. One other thing too, if somebody has their head leaning really forward as you're putting it down, sometimes people accidentally put it on the back of their head. Where you want it when their head is level, just 4 fingers toward the ceiling, like that.
Hey, Bill, did I miss it whenever, are we doing the paper towel thing on top of the sensors like the video or no?
Yeah, that's really helpful. Yeah, tearing off just a thumbnail size piece of tissue after you stuck the sensor down. Yeah, it's a good habit to get into. It's like the little microfibers in the paper towel act like rebar, kind of hold things in place really well. Yeah,
Thank you.
welcome. All right, Burnwood, I take it your lights are flashing yellow or flashing green? Yay! All right, cool. All right. So with your group, what we'll want to do is whoever is the most shy, you can all, Fernwood, you can all decide who is the most shy person who's going to be hooking people up. So they can practice with the most challenging place, because shy people tend to like not rub the hair, like rub the scalp enough, or they'll be likely to not put enough paste on the sensor because they don't want to mess up people's hair and things like that. So if you could all decide who might be the most shy person for the next protocol that we'll be showing you, this will be the most challenging one. That's often quite helpful. Or if there's someone who's just been kind of being the wallflower in your group, standing back, letting everyone else do that, they're usually the ones who would have the most trouble than getting the lights to flash yellow or flash green. So we'll want them to get the most practice. So who is the most shy in your group, Fernwood? Let's see Let's see you all point to the person who tends to be the most shy in your group.
I don't think any of us are really that shy.
Oh, got it. Then no worries. You're set. You're set. All right. So is there anyone now who's had any trouble getting your lights to flash yellow or flash green with this placement? Okay. Now I'll go to the most challenging placement. This particular one, I'll show you in a second here. That is... All right. So now on my screen here, you'll see this head screen sometimes where the ground sensor, here it's showing that it's on the left ear now. And then there's and look what sensor's on the right ear. There is no sensor on the right ear. And what that means is this one requires 2 scalp sensors. And so currently in your flat gray cable, you have a blue ear clip plugged in like this blue ear clip. So what we have to do for this one is we have to temporarily unplug it. And then in your BrainPaint kit, we have a bluish purple sensor in most cases, or you may, if you have our older sensors, you may have a blue scalp sensor yet. And yeah. Another thing also about these these sensors that are like this, these little clips like this, they will not work with any other of our older sensors. If you have any of these cup style sensors, these sensors won't work with them. You'll never be able to get your lights to flash yellow or flash green with them. They're not interchangeable like that. So if you have that purple scalp sensor, we have to unplug from the R1 hole your blue ear clip and then plug in your, it's usually a purple scalp sensor now that will go in the R1 hole of the black gray cable. So now you'll still have the green scalp sensor on the left side of your person's head, but you're going to have this purple sensor going on 4 fingers above the top of the right earlobe. And this is the most challenging connection because the scalp is more challenging than the ears. When you've all been doing what you've obviously been doing, because you all got your lights to flash yellow or flash green, you were thoroughly scrubbing the earlobes and the entire surface of it till they were pink. That will ensure your ears will never be a problem again. It'll just be the scalp sensor if you do have trouble getting your lights to flash yellow or flash green. And now we'll be putting the purple sensor in the R1 hole of your flat gray cable. And that's going to go 4 fingers above the top of their right earlobe. 4 fingers above the top of the right earlobe.
Is the green one going on the left ear 4 fingers up?
Above the left ear, I think you meant to say, right?
Yeah, what did I say? Yes.
Yeah.
Above the left ear,
Yep.
4 fingers up.
Yeah, 4 fingers above the top of the left ear for the green sensor. Yeah. When we see this head
I'm
screen,
gonna let you do your thing first.
I mean,
yeah, when we see the sensors are on the side of the head, they're always 4 fingers above the top of that.
It's all right, just put them together.
Yeah,
Here,
what-
here's Robin's forehead.
is there a big difference in like, depending on the person's width of their fingers? Because like his is way bigger than the rest of ours.
Yeah, no, doesn't matter. We actually have a clinical trial with 121 subjects. We found that didn't make any difference.
Okay, cool.
Yeah, one person had really small, dainty fingers. The other guy was a big bodybuilder, and the results were exactly the same. The reason is when the EEG comes through all the material from our brain out to our outer surface of our scalp, it blurs like a light bulb. It's not like a laser beam. So we can be off by an inch, up, down, left, or right, with no discernible difference. Similar question would come up with the kids. What if I have a baby I'm doing this with, which is very responsive to the work as well? It doesn't matter. It's still 4 fingers above the top of their ears as well. Yeah. Okay. Also, if you have any trouble with this one, getting your lights to flash yellow or flash green after you put them on, just let me know before you try troubleshooting it yourself, because I'll give you another tip that you might have missed before.
And so the black one is on the left ear, correct?
Yes, yes. One thing too about the black sensor, the ground sensor, it doesn't really matter which ear that sensor goes on. It could technically be on someone's big toe, provided it was scrubbed thoroughly. It's just completes the connection. Yeah. For anyone who has all three of these sensors on, whose lights are not flashing yellow or flashing green, I'll give you some tips for that.
Can you
Kristen.
help me with where, so I've got one on my ear, I've got one 4 fingers above my left ear, and then where's the last one go? Does it go on the right?
Yeah. Let's take a look. Yeah, let's take a look at this head screen over here for a minute, because you'll be seeing these, Christine. So yeah, you have the greens. This is your left side of your head, right? Over here.
Yeah,
And
I'm just getting confused because my colors are different.
your color sensors are different. I see, yes.
So
All
is
right,
that
so
4 fingers above the right ear?
yeah, yes, it would be. But let's do this, because given your colors are a different color, we can use the words with your system. So with your words, with these letters in the flat gray cable, there's an R, an A, and a G, okay? And so looking here at these words, where it says the reference, it goes on the right side of the head. And here down here, it says the reference goes in the R1 hole of the flat gray cable. So whichever sensor you'll be putting on the right side, your right scalp sensor, the color doesn't matter what color the sensor is. What does matter is that it goes into the R1 hole of the flat gray cable. Does that make sense, Christina?
Yeah. So
Cool.
I gotta switch them around then.
Yeah.
Ours, R1 is solid yellow?
Yes.
Okay, got it. So let's do this before we try anything else. Let's tear off have you already torn off a thumbnail sized piece of tissue, two of them to put on both sides of the scalp sensor?
Well, it's bigger than a thumbnail. Does it need to
And
be?
he said on both sides.
Well, if it's the size of a silver dollar, that would be a problem. It would work to pull it off. But if it was just the size of a thumbnail, it will never be a problem. So if you make it just the size of a thumbnail, maybe take that paper off and then tear off just a thumbnail size and then pack it down firmly with opposing pressure on both sides of their scalp. Just pack that down nice and firmly. Leave the sensors. Yeah, and then let go and watch your lights for like 20 seconds. About 80% of the time, that will take care of it. Yeah. That will. Yeah, this is the one that I do the most frequently. Cool. Good.
We thought it fixed it, but it didn't.
What was that?
Wait a minute, we gotta wait 15 seconds.
We thought it fixed it, but it did not.
No, wait, it's flashing. It's flashing now.
It is now. She just pushed a little harder.
We're good. Thank you.
Okay. Oh, one other thing too, if somebody was holding it as they're holding it and then the lights are flashing, then we wouldn't want that to be a solution. The little micro movements of their larger than their brain waves. All right, cool. Yeah, that tip of the little paper towel is most necessary for that particular placement because it is the most challenging one to get placements on because it's the left and the right. Also, the light that's not flashing will not be the one that's causing the problem every time either, just 50% of the time. So don't get deceived by that. If it was the A1 light that was not staying solid, if you just sat there working on that one, that wouldn't always solve it. We can know that the ear clips will never be a problem again when you're thoroughly scrubbing the earlobes hard enough as you were till they're stretching. So that's good. So everybody else who had trouble getting your lights to flash yellow or flash green with that one?
I'm still working on mine.
Oh, okay, Christina, and you're trying to hook this one up to yourself.
Yeah, I think it's my A on the left.
I see. Did you already tear off a thumbnail size piece and put it on both? Yeah, like I said, it's about 4 times harder connecting yourself than another person. I understand your person flaked out on you today. But we may need to just have you schedule an additional hour with myself or Rihanna. When you have someone and the machine to practice doing this, that might be valuable too. Yeah.
Well, I've got one blinking green.
Yeah, that's not going to cut it. And given that this one is the most challenging one to do on even another person, taking the time to try to get you to get it to flash yellow or flash green wouldn't be that great of a use of our time right now. But practicing, helping you teach it when you have a person you can hook up, that would be ideal. Could we do that, Christina?
Probably. I think so.
Okay, no worries, no worries. Yeah. All right. So is there nobody else had trouble with that one? What who here has your equipment, doesn't have someone to practice placing sensors with your cameras are off down there? I take it none of you are practicing this right now. I take it. Is that correct?
Yeah.
Oh,
Yes, that's correct.
Sorry. I was just saying I don't currently have somebody, but if we need to set it up, I can do that.
oh, we're done with this portion of the training right now.
Yeah.
This was the
Yeah.
most critical part of it too, also, of the whole training day. Sorry that didn't get communicated to you. What you'll need to do is schedule a time that you'll have your machine and another person to practice placing them. This is where the rubbers met the road. Okay. Who else here? Anybody else who couldn't do that? That will be a requirement to actually pass our oral exam, that you actually demonstrate your ability to get the lights.
Bill?
Green.
So
Yes.
some of
I've because I used to work with Neuro-Optimal, I've had a little bit of experience, and I have already attached these once earlier this week and ran a system on myself.
Yeah.
And then just did it with the camera off. I can do it again so you can see what I'm doing if you need.
I think that would be fine. Were you clear with what we call, I think Neuro-Optimal does a what we call a bipolar placement. Don't they use theirs is 2-channel training where you'd use 5 sensors.
One for the ear and then a scalp and a scalp.
Oh, it is. So it is just a 1-channel training. Interesting. Yeah, so you're familiar with that most challenging one that we did. Yeah, with this one too, you're clear that there's some that you have 2 ear clips and 1 active, right?
Yep.
I think you are.
We did that on, I think it was Tuesday when I ran this on myself, I had to use the purple scalp one. I unplugged the middle, the blue one, plugged this in, and I attached the purple scalp one following the direction on just like what you got here on your screen.
I'm very clear. Thank you, Kurt. You nailed it. No, that you'll be fine with. Okay. Yeah, it's just when you practice like this, it's just developing some muscle memory.
Yes.
And the thing too is, if somebody else teaches someone to do this, they often develop the wrong kind of muscle memory that they actually will have to unlearn, because they'll often have trouble getting the lights to flash 40% of the time. And then there's no results that are happening then when that happens. All right, go ahead, Nicole.
I just have a question about our wires. My person had to leave, but we don't have like the purple or the colors you're talking about. Even like for our green, we just have it labeled like with just this little sticky note. So I guess my question is, does it matter what the green cord is versus like the other cord we inserted for the right side of the scalp?
The color of a sensor that's going on the spot doesn't matter.
Okay.
Yeah, or the color of an ear clip that's going onto an ear, that won't matter. The holes that they go into does matter in the flat label. So here we can see on my head screen here, like the active sensor, that's a scalp sensor. We can see over here, it shows us that goes in the A1 hole of the flat gray cable, the active, the ground in the G hole. And then this one has another scalp sensor, that's the R1 that's going, that would be how many fingers above the ear on with this side would you say, Nicole? Where was this? Where
4, right?
4, you got it. Yeah, 4 fingers above the top of the right earlobe, that would be. And that would be another.
So it's not the specific cord that's a color, it's just the connections that matter.
You got it. It's all about the connections. Yep.
Okay, thank you.
Welcome. Okay.
And so we still want the top 2 to be blinking, correct? The bottom 2 we're not worried about?
Not for this particular approach. I'm going to show you another placement. We're not going to go through it, that we will need to use all.
So I think my top 2 are blinking.
Cool. Wow. On yourself.
That's good, right?
I'm not worthy. I'm not worthy. I have trouble doing that one on myself. But yeah, the flashing yellow or flashing green, those are equally acceptable. Way to go on yourself. If you could do this on yourself, you could do this with your eyes closed on another person. So very good, Christina. Um, Let's see. All right, I'm going to show you another placement that we're not going to actually practice on, but you'll see this. This is that nonlinear protocol that the software will come up with people with multiple chemical sensitivities and bipolar disorders by the nature of the assessment tool. So this is what that would look like when we have to watch all of the lights on the amplifier. Notice why we made this in big red letters over here is important. When you're using all 5 sensors, there's going to be 2 of them on one ear. And it says the metal ends on the left ear cannot touch for the R1 and the G sensors. So when we have those, so if someone has little tiny baby ears, you can put one on an earlobe and maybe scrub the upper cartilage of the ear up here and clip one up on the top of their ear. But if they have kind of average sized earlobes, they'll both fit nicely on the same earlobe. And then this one shows us where they go in the flat gray cable also. Was that you, Nicole, who had the different colored sensors? Do you have 5 sensors, Nicole?
Yes, like we have extra sensors in this little thing. So yeah.
And so you definitely have 3 ear clips and 2
Let me see.
sensors, right?
Let's see. Yeah, 1, 2, 3. Yeah, 4 ear clips, and then 1, 2, 3, or 4 scalp ones.
Okay, very good.
Yeah.
Very good. What is the name of your program, Nicole?
Beyond Therapy.
Yeah, interesting. Interesting.
Yeah.
Where they happen to get. Oh, I think you all did use some other neurofeedback system before BrainPaint, I think.
Did we?
I think you might have, and that's why they had other sensors. Yes, I think that's the case. All right.
We have old-fashioned clips as well. Like they're not the paper clips. They're like you have to physically clip them open and closed.
Yeah, that is a style we used also at one point.
Okay.
Yeah, where they're like earrings that you'd open up. And oh, one thing about those, Nicole, is that those will not work with our new sensors like these. Those other, yeah. If you get a new set of sensors, it also says they'll come with a package. It'll say, hey, these won't work with any other sensors. It says on the website as well. But if you don't get that memo, you might not know it if you didn't read the labels. That these will, you would never be able to get your lights to flash yellow or flash green if you use this style sensor with any other sensor. Yeah, they won't.
Got it. Okay. So when we switch to those, we have to fully switch to all of those new ones and not intermix.
You got it. Yep.
Okay. Okay. Thank you.
Welcome. So with this one here, we're using all 5 sensors in here. I'm going to quiz a couple of you. Let's see. Let's see. What is your name? Who's working with Amanda again?
Wilmaris.
Wilmaris. Hi, Wilmaris. Where would you put this sensor I'm pointing to on my screen right here? Where would this one go?
4 fingers above the earlobe.
Yes, which earlobe?
The right.
You got it. Yep. And then where would it go in your flat gray cable? This is the trick question.
I'm gonna say A2 because that's what thing is pointing at.
You got it. Very good. Very good. Yes, you just hadn't seen this screen yet. So I just wanted to be clear of that. And then, yeah, and then we can see where the sensor that goes on the right ear, we follow that up. Oh, that goes in our R2 hole. Very good. I just wanted to be clear on that one because this is the protocol that the software will come up with people with bipolar disorder and whatnot. So a couple of things too we'll cover before we're done with sensors. How do we clean these and how do we take them off people? This is how we preserve the life of them. Oh, Christina, hi.
Yes. I just wanted to make sure when we're saying right and left, we're saying the actual participants right and left.
Yes, you're correct. Yeah. And this would be like their nose here. And that would be their nose. And so this would be their left and their right. Very good. Kurt, hi.
Hi, I was going to say, please correct me if I'm wrong, but I use the same scrubby that I did for my head. I get alcohol on it again, and I gently, because they can be a little fragile, open up the clips and wipe off each clip until
Yeah.
it's clean. And I do the same with the ear, kind of just scrub it again.
Perfect. Yeah, that's what we do. You jumped ahead of me, but yeah, that's how we clean them. Yeah,
I'm sorry, I thought that's what you asked. I apologize.
no worries, no worries. Also, what we'll do is when we clean off, the people will usually go to take their ear clips off themselves, their scalps, and they'll go, oh, no, let me get those ears. Insist upon taking them off of them and putting them on. Never let the clients try to scrub their own earlobes too, because they don't know to scrub. They'll just be wiping and things like that. Or you'll say scrub, but they'll just wipe it. And so, yeah, don't let the clients do that. If they take them off themselves, they'll tend to break the sensors more, and the kids will get the paste on their fingers and wipe it on your furniture and things like that. So that will preserve the life of them. Three things, too, that will help preserve the life of them. And I'll say it in the order of preservation. When it comes to cleaning the sensors, being mindful that we're not bending any metal when we're cleaning them. Like Kurt showed us with the paper towel, how he had it soaked in alcohol and he just kind of like wiped it like this and like that. We're not bending any metals back and forth. That's one. Well, another place to, and then we also clean off their earlobes and their scalp. I tend to do that as well, saying, are you okay if I take that paste off your earlobes and off of your scalp? They're like, yeah, go ahead. So preserving the life of the sensors, that was one. The most is being mindful that we're not bending the metal as we're cleaning them. Anytime you bend metal back and forth, it weakens it. And if we're cleaning them without bending the metal, that will cause alone your sensors to last you for at least a year more. Two other tips to make them last forever. One is when it comes to putting the paste on the sensor. If you're taking the sensor and then you're dipping it into the paste like that, it'll have a tendency to bend a little bit every time you do that. And every time that they bend, it's shortening the life of it. So if you put the paste on your finger first or an applicator stick and then smear the nice half of a pea size on it, that will make them also last a lot longer. And the third tip is when we're sticking it down. Sometimes we're like, oh, I don't want to get that paste on my finger. So if you push down on the like this part of the sensor, then the metal will bend every time you push that down. So you want to put your finger on the back of it when you push it down. That's where if you also tear off a thumbnail sized piece of tissue and have that ready down too, you can just push down on the paste of it push down on the paper towel piece of it as you're sticking it down like that, and then pull it away and your finger won't stick to it pulling it off. But those are the three ways, but primarily cleaning the sensors, being mindful that we're not bending the metal will make them last the longest. Any other questions about, yes, Kurt?
I feel the clips are very comfortable. Have you ever run into a client who feels that they're pinching the ears too hard? And if so, what do you do?
Yeah, good question. One thing about that, I mean, there's two. You bring up a very important thing. I mentioned it really, really briefly. Like when someone says, "Oh my goodness, you have to have ear clips on my autistic son." Oh no, how is that going to work? Well, if you're fearful of him freaking out when you put that on because of that, they'll be freaking out before you even get near them with the sensor. I think we emit pheromones based on the size of the picture that we're focusing on in life. So if it's about, oh, am I or am I not going to be able to get this on? It's a very small picture that we're focusing on versus this isn't about the little half hours. This is about preparing that kid for the tens of thousands of hours of their life. So in terms of that, if I have a very angry, cantankerous, impatient client who's like, oh, what's it doing? It's hurting my ears. And we react to that. Now we're amplifying this belief with them. We're amplifying that as we go into sympathy. One thing one can do, there really isn't anybody I have ever had who couldn't handle it unless I'm doing 2 or 3 sessions in a day and I'm leaving the sensors on because I'm just giving them 20-minute breaks between each sensor. Then what I've done is with this style ear clip anyway, if you open it up like this, I could put like a little cotton ball in there. So that notice how like if my finger were a cotton ball, it's not closing all the way. I could put something in the little chamber but pretty much only if you're doing many sessions like that like multiple sessions in a day. Everybody can tolerate having that on their ears. Even the autistic kids who would scream if a collar touched their earlobe can handle that. If I'm making it a big deal, they're going to make it a big deal. Or if they're making it a big deal before I even did it, and then I react to their big deal, now we've co-created that reality with them. Yeah, similarly with our providers who are working with the A-list actors who are on set and doing a session, they just had their hair done. If they're like, oh goodness, am I going to mess up their hair? Oh no. They're freaking out too about their hair getting messed up before we even bring up the sensor. It's transference that we induce that in people. But when we hold the larger picture view of what this is and not what's happening in these little half-hour segments of their life of these sessions, there's this amazing compliance that happens that you don't tend to get otherwise. Other questions? You're welcome. Okay. All right, so what I'm going to do next is I'm going to show you how we run the 2 types of sessions in the last 15 minutes of the day. This is the alpha theta sessions and everything else. I'll go back to the alpha theta work. So when we open a client file, we'll see minutes in this little box up here. These are only protocols we're concerned about that have minutes in them. When there's alpha theta, there'll always be 10 minutes of eyes open only work that are required. Otherwise, people have some other negative reactions we see in our metadata if they don't do the 10 minutes of eyes open only work in addition to alpha theta. Other than the first session, which I'll show you what will happen. There's an item in the assessment tool that said about panic in it, where it asks, do you think this client would work themselves up into an anxious or agitated state if they sat quietly with their eyes closed for a half hour? It wants you to give an estimate of that. Or if they had outright some very classic symptoms of panic. That was in the evaluation tool. Well, when you asked that of them and you endorsed this item that was about panic or that other item, the software is going to help them out by giving them this, what we call a distraction exercise. It systematically desensitizes them to the feedback process itself initially, with initially the 7-minute protocol. So I just hit the save notes and start feedback button, giving them a double session today. So when we click on the alpha theta button like that, when we've done the full evaluation, we're going to see this sometimes when the software says, hey, I can knock 7 sessions of progress off this client's experience. You want me to help you with that, is what it's saying in this pop-up box. And so I'm going to say yes to that and first walk you through what that looks like. I think I can plug this amplifier in. Okay, so I'll say, yeah, guide me through this distraction exercise. It's changing the minutes here on us, like I pointed out before, and now it's on our head screen. To pass the oral exam, we're all going to make sure that our top 2 lights the correct lights are flashing yellow or flashing green after we placed all the sensors on their head. Now I'm going to hit the start protocol button. And when we can't move the mouse with BrainPaint, that's never a problem. It's just not wanting us to get in its way. And you're going to be seeing a lot of this with AI, what they're called large action models, where computers can not just crunch information for you, but will actually do things on your behalf. BrainPaint's been doing that for 18 years now. And it's setting itself up now. So there's nothing broken with it when you can't move the mouse. You're just not used to a computer clicking things and sending files and doing all this other stuff for you. I'll bet within a year, software is going to start doing this. And some things can take different times on different days too. And that's also not a problem. That happens when around the first of the month, Microsoft forces updates on us all, and things will sometimes run more slowly as BrainPaint's navigating through all the things, the hurdles they're putting up for it. But I'm not doing anything right now. The computer's doing all of this stuff, so you don't have to remember all the stuff the computer's doing now. Okay, so this is the feedback screen for all the beta sessions. I think I'll be able to simulate some EEG here for us. What I'm doing is nothing you would ever need to do. There's so many things running in here. This is also why we have turnkey systems too, so that you don't try to run sessions while you're doing Zoom meetings and making PowerPoint presentations. So the distraction exercise, you won't be able to hear any sounds that would be happening anyway when someone is hooked up during this anyway. But when you see this come up front and center, you just have to read this to the client. It's explaining to you what it is first, and then it says below are some instructions intended to be read to clients. That it's saying that this is a process that makes a training more overcome panic much more quickly and to enjoy the training process in subsequent sessions. Below are some instructions intended to be read to your client. So to sit back in your chair at about a 45-degree angle. I'm going to start by saying your toes. After I mention each body part, I'd like you to think to yourself the words, I thought about my toes, but out loud to me, say, okay, so that I know that you've finished doing that. And then I'll say the arches of your feet. Then out loud, you can say, okay, and I'll advance it. The purpose of this is only to have this call and response thing. Most clients won't do that when you say ready to start. They'll say, okay, and you'll say your toes, and they'll just sit there. They have to say, okay, out loud after they thought about it, because they have to be hearing you who's in reality and responding to you in reality. When they do that, they can't dissociate and go into these other horrible places where they have flashbacks and things of that nature. So it's distracting them from it. It could be anything. If you have people with body dysmorphic issues or what have you, or eating disorders, and you don't want them kind of focusing on the body, you could say the catapult on the table. Okay, the vase. Okay, doesn't matter what it is, in place of what the software's saying. But they'd have to be sitting back in the chair at a 45-degree angle, like it's saying here, and explaining these instructions. Ready to start, client? Then they say yes. Then in one sentence it says, close your eyes and tell me okay when you thought about your toes. If you are feeling like, oh, I think this client's going to freak out, if they close their eyes, then they would be freaking out if they were to close their eyes. Oh, Christina, what was your question?
You kind of lost me on this one. so this is going to come up on the client's computer that they're going to be using, but you're going to read it to them?
Yeah. I'm sorry. I'll start it over. Oh, let's see. Can I start it over? Yeah, the machine said this is intended to be read to your client. You follow me, Christina?
Yeah, and so the prompt that you give them, that's only before they start the protocol or throughout it?
It's as it's present. Whenever BrainPaint shows you something, it's only to be used as it's present, and it'll be telling you what to do at every step along the way. So when it's done, it'll tell you when it's done. There's not much that you have to like learn and try to remember with BrainPaint. You just have to like read these little prompts that come up like this. Does that make sense, Christina?
And that would be throughout the protocol.
Until it's done. Yeah, I'll show you and then you'll know. You can't kind of know before we do it. So hold on. I'll just go through and you'll see exactly what this does step by step. So this is close your eyes and tell me okay when you thought about your toes. And so then they close their eyes and they thought about their toes. And then you click OK. Then it says your arches. And you just go through this as these things are coming up like this. You see how they keep popping up? Your thighs, your hips, your waist, your lower back. Okay, okay, okay. Making sure that they're saying okay to everything that you say. And that's where they're listening to you who's in reality and responding to you who's in reality. Does that make sense? So you just do this. This takes about 5 minutes of the 7-minute protocol. And then, because the computer changed the minutes for you, so you don't even have to calculate that. It's set the minutes for you. You just go through this. And when it's done, it gives you the last instructions to tell them as well when it's finished. Does that make sense? Here it is.
I have a question.
Well, hold on a second. Hold that thought. I'm finishing with Christine. Her question was, how do I know when this is done? The machine will tell you when it's done, just like this. It says, before pressing OK here, read this to your client. So this is answering it. Does this answer your question, Christine?
Yeah, so up until this point, you are the one that has the computer. You haven't like set up the client with it yet?
No.
No, okay.
On the screen, we'd hook them up. Then we hit the start protocol button. I'm just going to go back from the beginning because this is important. Who else had a question meanwhile?
Me.
Yeah.
Well, my name's Sherry. I should probably say that. How fast do you say toes, thighs, feet? Is it like 10 seconds apart? Or as soon as they click OK, you say the next thing?
Well, they're not clicking OK, they're saying OK, and you're clicking.
That's what I meant.
Yeah, because they have the computer told them to do it with their eyes closed.
Yeah, no, sorry. I meant, are you doing it as rapid as you were going through them? Like toes, okay, I click. Thighs, okay, I click. Or like 10 seconds in between each one?
No, it'll just be kind of a conversational, like I'll demonstrate it how I would do it with a real client here in a second.
Okay.
So, Christine, I opened the client file. I said, okay, client, ready to do your first session today? And I hit the start session button. I saved the notes. I got to the head screen. There's no questions to ask about their growth areas. And I get to this, I hit the save notes. It takes me right to this screen here. I clicked on this. The alpha theta, it's saying, hey, Bill's suggesting, blah, blah, blah. I'm doing all this. You understand me? The machine is saying, Christine, do you understand what I'm telling you here? I'm reducing this session. I'm going to give you this distraction exercise. I'm going to tell you how to administer this distraction exercise. Are you ready to start with me? Do you want me to help you with this right now? All you have to say is yes, okay? And now it's saying it's reducing the minutes to 7 minutes, and it's going to do the distraction exercise for you. But first, it has to show you where do you place the sensors. So after you click OK to this, it does that. You follow me? There's not all this stuff you have to go read a manual and, oh, when do I do this and when do I click that and it's all a sequence. The machine sets it up so there's no room for error. that you can't like miss this screen or that screen, or even the prompts that come up. There's no way to forget that. You don't even have to click anything to make it prompt you like that. Okay, following me? Okay, so now on this screen, what do? We have to place the sensors. So we put the blue sensor on the left ear, black on the right, and now we're putting the scalp sensor back middle of their head where it won't be touching on the back of the chair. Then, most importantly, we then check, are your top two lights flashing yellow or flashing green? Yes. Then and only then do we click the Start Protocol button. We click this, now the machine's taken over control. It's setting up, doing about a 200-step process for us, actually, as it's setting up these thresholds, these inhibits, these rewards. And we just wait for about a minute to 3 as the machine is doing this other stuff for us. Then it's going to bring up front and center those instructions. And why it's going to tell you, clinician, why it's doing this and then what to do for the client. Step by step, and that's where I'll demonstrate that when we get to that screen. But right now I'm not doing anything. The machine is just running itself here.
Hey, Bill, I have a question for you.
Sure.
I've got a television in my office that I use for other therapies. Is it okay if I hook up a USB to the BrainPaint laptop and have it project onto my TV so the client's watching the TV versus a small computer screen?
You can, yeah, you can do that. There's no additional benefits. It's not going to work any better. You'll have some more additional moving parts to it, where you'll have an HDMI cable to manage. Make sure that it is an HDMI, and do not do any like Wi-Fi connections to any monitors or sound systems or things like that, because those through any wireless things can create delays. And if there was a half second or more of a delay, there would be no feedback happening. Yeah. So
thank you. No, that's fine. I appreciate that.
Yeah, no worries. Okay. So now here's where the machine, the computer had clicked on some things as it was going through. I have so many things running on this computer. But it had given the instructions. Is somebody, what's happening here? Can you all hear me okay? Okay, cool. Very good. I'm seeing a note saying that no one's hearing anything. So these are the instructions where the computer said, here, I'm just going to do this. What I'm doing is nothing you would ordinarily need to do. This is the instruction that always comes up like this. You see this, Christine? So this is explaining everything to you and then giving you the instructions to tell the client. So we found this simple method to be extremely valuable in helping clients overcome panic much more quickly and to enjoy the training process and subsequent sessions. Below are some instructions intended to be read to your client. Okay, so then you read this. Sit back in your chair at a 45-degree angle. I'm going to start by saying your toes. After I mention each body part, I want you to think to yourself the words, I've thought about my toes. And then out loud tell me, okay. And then I'll say the arches of your feet. And then out loud you tell me, okay. Ready to start, client? Ready to start, Christine? All right, cool. So then and it says press yes when your client indicates they're ready to start. So I click that. Then it says, close your eyes and tell me okay when you thought about your toes. And so here's where they'll usually just sit there. They'll close their eyes, but they'll just sit there. And then you have to say, oh yeah. And then after you just thought about your toes, tell me okay. Then they say okay. Then they'll say your arches. This is like the speed that I would do it at too. Your arches, I'd say, okay. And again, remember, say okay after you just thought about your arches of your feet. Okay. And then I click okay. And your heels. Okay. Your calves. Okay. That's kind of the rate. When they say okay, I say okay pretty quickly. The thing about this is it's not intended to be a progressive relaxation exercise, and do not replace it with one, because this is intended just to have this call and response thing that prevents their neural networks from running into these positive feedback loops where the more anxious they feel, and they escalate. It's just distracting them from those networks as they're hearing the feedback sounds as well. So they're getting used to hearing the sounds that are directly related to everything they think and feel, are creating every music note that they hear. Their brain's producing that in all feedback. Every musical note is not an arbitrary sound that we're playing that's supposed to induce a relaxed state. They're all directly related to mental and emotional states a person's feeling as a brain network that makes people with PTSD, addictions, and developmental trauma feel miserable most of the time. It's called the default mode network. As that network starts to activate, more sounds happen. As it's deactivating, the sounds start breaking up like a speaker and they start getting louder and higher in pitch. Don't tell the clients that though, because if they're trying, they will try to control them with their thinker. And if they could control their mental states with their thinker, they wouldn't need therapy or neurofeedback. So it's a passive training process with alpha theta in particular. So we just say okay, or when the client says okay, rather, we click okay on each of these items. I'm just going through it fast now to get to this last one. It takes about 5 minutes of the 7-minute protocol. And then when it finishes, we just ensured they had a neutral first experience. No experience whatsoever. No brain training ever can happen in 7 minutes of feedback for anybody. But what we did is we just ensured that they had a neutral first experience. When people develop phobias, what's actually happening is they get their anxiety levels reach a certain level in the context of some scary thing. And then our brain encodes that as being dangerous. We have a phobia. And when that would happen with people who need alpha theta, who might endorse that about panic item in the assessment tool, we're preventing that from happening around the neurofeedback system itself. Because whenever they have a panic attack because they're not doing something, they would feel like this caused it. And so this method is preventing that from happening. So now it says just sit here for the remaining minutes and just let your mind think about whatever it happens to. There isn't anything you can do with the sounds or know about the sounds that will make this process work better. The sounds change as you feel the slightest bit more anxious or more calm. Your brain can be guided by the sounds to learn how to balance more in calm states. This is experiential learning that's similar to the way you learned how to ride a bike. This type of learning doesn't require thought or understanding on an intellectual level. Again, just let your mind wander onto any places of consciousness it happens to without trying to direct your thoughts for these remaining minutes. So this would be about 2 minutes left. If you want the research that's identified the impact on neural networks with this, we have 5 clinical trials now. 4 used fMRIs at baseline, one of our PZ alpha suppressions that BrainPaint delivers, and a post fMRI. Another did it with a PET scan, and another one just published a study with a group of PTSD participants in a double-blind placebo-controlled trial, also using physiologic measures. The EEG doesn't move in the direction they're encouraging it to, but we see with neuroimaging technologies, very specific brain networks turning on that imprisoned people, addicts, and people with PTSD, where we can see with the actual neural networks, not the EEG, how we can use the EEG to change the networks, even though the EEG doesn't change in the process. But that's what happens with our alpha theta sessions, and this is how we would do it with this population. When it's their 3rd session, and beyond. These are the people with panic. When it's the 3rd session, we don't see that distraction exercise come up anymore. What actually happens is when you get to the feedback screen, this comes up instead. And this is a pre-recorded guided visualization. There's one in here for kids. We'll get more into that next week when we come to working with kids. But there's a children's script because the others are too they're too abstract. And with these, it will default to this one with Xena. And are you running a session on yourself? You'd only say yes if you were, of course. But here, once you get to the feedback screen and you see this, you would click the Play Now button for the client. But you can't miss it because it just comes up front and center over everything. The thing with this guided visualization, if we don't do these because we're trying to save time, all the symptoms of PTSD go away pretty quickly, but re-stimulations don't go away. So the things that would trigger someone to react from events in the external world, which is usually the worst symptom of PTSD, will still be at square one if they're not doing the guided visualization. So if you're trying to cut corners with something or streamline things, I can teach you how to do that, where and when you need to. But that's, very, very important. So when you see this, then you'd click it. What I would do in the first session or two is I'd say, now the machine is going to be giving you some things to think about. It will be telling you to think of something, some positive qualities you'd like to further enhance. Then it will be asking you to think of a scene you'd like to move through with more grace and ease that's otherwise stressful for you. Then it'll be asking you to set an intention for that. Then it will be asking you to just let your mind daydream. It'll tell you some things to do or not do for the remainder of the session. So that with alpha theta sessions are very easy in that regard. They just tell the client everything to do at every step of the way. You can't really miss it. So if somebody was doing it with their eyes open, the machine said do it with your eyes closed. Again, alpha theta will not work if people do it with their eyes open. And the machine even tells them in every way it can be delivered, the two ways it can be delivered, to have your eyes closed. And if they didn't want to, like some of your clients get character disorders, would say, oh, I can't, or it'll kill me. We'd say, oh, we better reschedule the appointment then. You better talk with your clinical therapist or your therapist on that because we can't do it that way. And then they comply, in my experience. So that is the guided visualization and the eyes closed work. Alpha theta is the only one that we do with the eyes closed. Everything else, you won't see this come up in the eyes open protocols. The screens look identical, except it won't be prompting you with this guided visualization. So it won't even show you this button down here to accidentally click on. In the eyes open training, what do I have to do for this to work for me? All I have to do is be still enough so that the brain waves are staying below the tops of the green letters. And I will show you what that looks like here. Let's see if it'll let me replay some brain waves. No, it won't let me play any waves here. So in the eyes open protocols, what we do. Oh, my computer's frozen. Okay, that's cute. What it just did, I found a way to minimize the screen, but the machine identified that I did that, put everything back in place. So the eyes open training, there'd be brainwaves moving across left to right on the screen. These are the green letters here. We just have to be still enough so that the brainwaves are not going above the tops of these green letters, and they can look at anything they like on the screen. And when they see any blue in this what is and what isn't graph, they click the right mouse button to prevent it from turning all blue for as long as they can. And yeah, that is it. Okay, now I can play some brain waves here. All right. Okay, so these are the brain waves that are moving across the screen like this. And they just have to be still enough. When they move, the brain waves go above the tops of the green letters. And as they're below the tops of the green letters, they're doing everything necessary for this to work for them. And they can look at anything they like. It will work exactly the same. If they were looking at the fractals, they were looking at their brain waves, they're looking at this graph, doesn't matter. What we want to do, when you see any blue in the what is and what isn't graph, you click the right mouse button, like it'll never do it when I'm waiting for it to do it. There. I clicked the right, there's some blue in this graph here, this graph right there. There was some blue. I clicked the right mouse button to prevent it from turning all blue. Make a note of that. That's all clients have to do. You just have to be still enough that you're keeping your brainwaves below the tops of the green letters. This is everything besides alpha theta, that is. And that is all they do during the eyes open training. Still enough that they're keeping their brainwaves below the tops of the green letters. When they see any blue in that what is and what isn't graph, they click the right mouse button to prevent it from turning all blue for as long as they can. There's a bunch of numbers and things on that screen. None of that is going to make this work any better for them. Everything I mentioned about clicking the right mouse button when there's any blue in that graph to prevent it from turning all blue, there's nothing more they can do or learn that's going to make this any better. We can, like I said, do this with animals who don't understand the instructions. We can get rid of infant seizures very rapidly with this work as well, without their understanding a thing, just getting the information. The reason is when our brain develops any new abilities, it only does it through nothing but information. So you're standing on a slippery board on a slippery hill and your eyes are open when you're on a snowboard, your brain is rewiring itself through real-time information. You can learn it with your eyes closed, but when your eyes are open, you'll learn it far more efficiently. The fractals on that screen are conveying very specific information about shapes of the brain waves. There's literally an infinite more information in the shapes of brain waves than there are in how big they are and how fast they are. From looking at the screen, anything they like on the screen, clicking the right mouse button when there's any blue in that graph is all that they need to do for this to work for them. So that is it. Practice, practice, practice is the absolute necessary thing to do next. We covered how do we explain it to clients, that is what it is and how it does it. There's brainwaves that are related to how we feel and how we think. We convert the brainwaves into real-time information, show it to our brain, let our brain hear it, and the brain self-regulates. It learns how to balance mental and emotional states in the same way it learns to balance on its skis on a snowboard. When it comes to doing the training, the evaluation tool identifies what the best starting protocols are and how do we place sensors on one's head. That is everything I wanted to cover with you all today. It's a pleasure. Any questions on anything? Also, I'm sorry I went over by 50.
We do have a question.
Go ahead,
For the
Nicole.
next trainings, do we have to have the computer with us? We only have one. So do we all need to have access to the computer for the next trainings, or no?
Oh, say that again. Go ahead. What was that? What was that again?
Yeah, for the next trainings, do we all need to have access to the BrainPaint computer, or we won't use it again?
No, we won't be needing the computer in the trainings and the subsequent trainings, just this training day one. But using it to practice on, though, between now and then will be really helpful that everybody gets some practice on it. Will cause everything else to fall into place. Without the training, it would be it would seem like you'd have to remember things, and you don't have to remember much during it, except for placing the sensors. There's things to remember with that. Everything else, the computer gives you that you need to know it as you need it. Other questions? Nicole.
Yeah. I have a question about like when you say practicing outside of here on the computer, what would practicing look like? Like, should we be starting a protocol on ourselves and actually do the brain paint protocol, or should we just be like kind of messing around and Xing it out?
running it on anybody, running it on yourself,
Okay.
doing a full evaluation and all the protocols on someone is what practice, whether
Okay.
it's yourself or someone else. It's a mistake to wait until you're done with the whole training to start practicing on other people. We will be covering some tips next week on working with kids who are 8 years old and under that can be valuable, but there won't be any other value we'll be teaching you that's going to help you be a better clinician at running this with adults than what we covered today. So there isn't.
Got it.
Yeah. Yeah.
Okay.
Yeah.
So real life, like we should be getting like real friends, real people to come in, actually do an evaluation that's true to themselves and run the protocol
Absolutely. Yeah.
in
Yeah.
this training phase. Okay.
Yeah.
Okay.
Yeah. Between now and next Friday, actually.
Okay.
Yeah. Yeah.
And then can we also get a recording of this session?
Yeah. Email me, bill@brainpaint.com, and put that in the subject. I get a ton of spam emails, but put it in the subject, training video, recorded webinar for today. I'll have those up by next Wednesday. I'll have those up. I'm going on a road trip right now through Monday.
We have a couple more questions. Can you send the 120-page manual in the chat?
Yes, thank you. I forgot to do that.
And then for our meeting that we need to schedule, should we do that all together, or we should each have our own individual time with them?
It would be, I mean, that it would be ideal if you did it as a group. Then you could avoid some of the he said, she said stuff when you're with a group with the individuals. That tends to go a lot further because often people will hear think we said different things than we didn't and all of that. So that makes it more efficient if we can do those together as a group. But if you can't do it as a full group, individually would suffice as well. Christina.
Do you still think that I should schedule a additional meeting, or do you think I'm good because the lights were blinking?
Good question. When would you be able to run a session on somebody else?
I'm sure I probably could sometime next week.
That would be ideal. How about you try that and see, but if you're feeling really lost or things like that with that part of the process, then check in with us on it. Or if you ran another session on yourself, like I'm not kidding, if you got your lights to flash yellow or flash green on the sides of your head like that, you should have no trouble doing it on somebody else. But yeah. So you could do it. I don't know how to exactly answer that if you should or not. Most people in your situation would likely be fine if you did it on yourself. So when it comes to doing it on another person, it's just way easier. If you use all the steps that were necessary to get the lights to flash yellow or flash green on yourself, getting the paste on the sensor first, scrubbing the spot where you don't lose it, scrubbing the earlobes, you'll have it. Yeah. Alexandria. Yeah.
I'm sorry. I was literally leaning in to see my screen more, and I talk with my hands to myself. This is why I need neurofeedback for myself.
Nice. No worries. No worries. Anyone else? All right. Well, I hope you all have a fun weekend. I'm planning on it. Thanks for spending the day with you. It was fun and looking forward to next time, whenever that is. Talk to you later.
Thank you.
You're welcome. Bye-bye. Bye.